Good morning, everybody. May I start?
Good morning, Dr. Nicola. We need to wait more 3 minutes to
Okay,
start
okay,
for
okay, okay.
introduction.
Thank you very much, dear. I'm trying to do share screen and tell me when to start. Okay, thank you very much.
Okay, fine. Um, I would request to our speakers if anyone is experienced with live video, then they can share the live video link with their team or with their social media. That's not a problem. Thanks. Yeah. Hello. Good morning, everyone. Do you all hear my voice?
Yes, yes.
Good morning.
I request
Good
all
morning.
of our speakers to unmute first. So, my name is Gitanjali Rao and I am from India. Welcome to the International Meet on Neurosurgery and Spine organized by Live Medic Talks. We'll begin shortly. Kindly keep your microphones muted throughout the conference, not now. You can also use the Zoom chat box for any queries if required. Good morning, distinguished professors, respected doctors joining us from different parts of the world. I sincerely thank each one of you for taking the time to join us today. Before we begin our scientific sessions, we would like to have a brief introduction section. I kindly request all of our distinguished speakers to introduce themselves by mentioning their name, country, institution, area of expertise, and for about 30 to 45 seconds of introduction. Everyone has an opportunity to participate. Thank you so much. If anyone didn't understood my voice, then I am sending the same text in Zoom box so that you can understand better.
Yes, thank you. Hi everyone. Good morning. I am Dr. Saif Anwar from Iraq, working at Ibn Sina University for Medical and Pharmaceutical Sciences. I am a neurosurgeon working at Ibn Al-Saad al-Witri Neuroscience Hospital, especially the neuro-oncology and spine surgery. Thank you.
I continue. My name is Zoltver Alexander. I'm also a neurosurgeon. My field of interest is spine surgery. I work in spinal department of one of the German hospitals in Erlangen, and my field of interest, except the spine, robotic surgery and endoscopic surgery.
Good morning, everybody. I'm Nikolaos Sirmos. I'm from Thessaloniki in the northern part of Greece. I'm working in Papanikolaou General Hospital as consultant neurosurgeon, but also I'm working as teaching staff in the Aristotle University of Thessaloniki and also in the International University of Thessaloniki. Mainly my interests are in trauma and emergency neurosurgery, also in pediatric neurosurgery, but I have also other interesting in surgery such as history of neurosurgery, sports neurosurgery, and many others. Currently, I'm also an active IWNS member, and I will write to my email to the chat if some colleague wants to communicate for me with some scientific topics. It is a great opportunity to be here. I also participate in the past in other webinars organized by this organization, and I'm very happy to be here. The only problem is that it's a little bit early. It is 6 o'clock in the morning here in Greece. But okay. Thank you very much. It's a great honor to be
Thank
here
you,
and to
doctor, for
see
your.
other people. Thank you very much.
Hi, I'm Kai Cao from China, and I'm the chief spine surgeon and professor and vice president of the affiliated rehabilitation hospital of Nanchang University, China. And my clinic interests are the spinal deformity and cervical deformity and other degenerative disease of the spine. Thank you very much.
Hi, can you all
Thank
hear
you,
me?
Dr. Kai.
Can I continue? Okay. My name is Marcos Vinicius Brito Marques. Good morning for all. I'm from Brazil. I work at the Federal University of Bahia. I live in Salvador, and I am an orthopedist, spine surgeon, and I have an area of interest in spine endoscopic surgeries.
Thank you, doctor.
May I start?
Hi, I'm Dr. Anudeep Ekula. I'm from the United States. I'm a neurosurgery resident at the University of Minnesota, and I'm a research fellow at the Mayo Clinic. My interests are neurosurgical oncology, and my expertise is liquid biopsy for brain tumors. And thank you for inviting me.
Thank you, Dr. Anudeep. I would like to request Dr. Marcus, Dr. Renato for their introduction, and Dr. Saif, please give your introduction so that we can start our first topic. Thank you.
Hello, I'm Renato Kish. I'm from Brazil, University of Araraquara. I'm cranial-based surgery and the oncological surgery. Today I will talk a little about a hypothesis of surgery.
Thank you. So, could I request all of you to unmute your video for 2 seconds so that I'll take a group pic for organization. Could you hear me, please?
Yeah.
Yes, we can hear you.
I would request to Dr. Elson to give his introduction, please. All of you, please unmute your video for 2 seconds so that we can take a group picture for our organization.
Are you hear me?
Yes, yes.
Uh-huh.
Dr. Saif Anmar, I think we didn't had your introduction. Could you please unmute yourself and give your introduction? Dr. Saif from Iraq. Yes.
Sorry. Shall I start my subject?
No, you need to start your introduction first.
Yes. I am Dr. Saif Anwar from Iraq, a neurosurgeon working at Ibn Sina University and Saad al-Witri Neuroscience Hospital, working skill base and microscopic spine surgery in Baghdad city. My subject now or today is a new surgical classification for a colloid cyst of the third ventricle. Yes, thank you.
Thank you so much, Doctor. So I would like to request Professor Nicholas Ermos from Greece and to present the topic complex cervical spine surgery. It's my great honor to introduce our first speaker, Professor Nicolas Sernos.
Thank you very much. I think that my topic is diverse that what you said, but
Yeah,
okay.
that's okay.
It is for
Please announce
penetrating
your topic
for
and continue.
penetrating brain injuries. Thank you very much. It's great pleasure to be here with all the distinguished colleagues from many countries. I will present a topic uh, about penetrating brain injuries. It is one of my field of expertise since many years. This is my name and my email. If some of the colleagues wants to communicate with me, I will be happy, more than happy. And if we can introduce this specific topic, we can see that the penetrating injuries can also be combined with skull fractures, can also combine with foreign bodies that can be inside the head of the people. We can also speak about the diffuse injuries that we can see the blunt head trauma, the blunt injuries, and sometimes we have also cases with diffuse injuries that can provocate many problems inside the head of the people. Because we are speaking about neurosurgery, sometimes we have also penetrating brain injuries also in the spine. But my talk today will be also about the head penetrating brain injuries. When we speak with for penetrating brain injuries, we are always speaking about traumatic brain injury, and we have to see some cases with diffuse axonal injury, axonic brain injuries, secondary brain injuries, prime injury, concussion, and additional type of traumatic brain injuries. Uh, we can not forget that the brain injury is a trauma effect that affects all the aspects of the on-day life of the patients, the quality of life and the health-related quality of life. And this is one of the first messages that I have to give with this my speech. In this presentation, I will present two cases. The first case is an unusual penetrating trauma brain injury in skull in a young worker, delivery pizza boy, in presenting and discussed. The accident was due to a high energy crash against a metallic rod in the construction site with a good neurosurgical outcome despite the dramatic clinical conditions on his admission. Sometimes these injuries have dramatic clinical conditions when they are presenting to the hospitals. This is a lateral X-ray plane of the skull, demonstrates that the trajectory of the metallic rod, which enters approximately 1 centimeter above the supraorbital rim, involves the frontal sinus and points through the right temporal lobe for an intracranial length of 14.5 centimeters. This is the post-operative axial CT scan of the head, shows the entry point of the metallic body, causing radiographical artifacts. The frontal horn damage can be suspected because of the bilateral intraventricular hemorrhage. This is the post-operative photograph of the metallic rod, which had a diameter of 6 mm and a length of 35.5 centimeter. This is the post-operative axial CT scan, demonstrates the residual contusions in the right frontal lobe, and in particular the presence of the blood in the ventricular system. 5 major modalities of penetrating brain injuries may be identified according to our personal experience and according to the literature. Violence, road traffic accidents. We have many cases in Greece, but also in the whole Mediterranean area, in the Balkanic area, and also in the East Europe. Home accidents, suicide attempts, and sports activity. Noteworthy, a significant relation between age, comorbidity, and outcome has been outlined, suggesting that mortality is higher in patients over 50 years of age. Surgical intervention as soon as possible in combination with aggressive intensive care management is the gold standard in the management of such patients and already has significantly reduced the mortality and the morbidity associated with these injuries. This is some common traumatic events causing brain injury, the traffic accidents, the falls, the violence, the combat injuries, and the sports injuries, according to the literature. We have many cases in the mechanical sports, but also in motor sports, and this is the motorbikes, very famous in Greece, that we have with these motor electric bikes, many cases, especially in young patients. The helmet and the prevention is very important, and we have to follow the road traffic rules. This is a very important topic. And the second is case is the penetrating a hemispheric traumatic brain injury due to gunshot. Case report. A case of a deep penetrating traumatic brain injury in a young patient is presented and discussed. A severe head injury was caused by a homicidal gunshot. The young patient was transferred comatose in the department of emergency, intubated and ventilated. It presents a right port region entry wound and an exit wound in the right occipital area, a depressed skull fracture in the entry point of the missile associated with an intracerebral hematoma. A right posterior parietal craniotomy was performed for the evacuation of the hematoma. The necrotic brain tissue was removed as well as bone fragments that they were fed by gentle irrigation. He had a slow but constant recovery, and 35 days later, he was discharged with unremarkably high mental functions, but with severe motor problems and left side weakness. The penetrating gunshot injuries has enormous medical interest. Each year, fatalities in all over the world increase as a result of gunshot wounds. This is the main reason that they are one of the most devastating cases of morbidity and mortality in civilian population. The majority of the victims will not survive, and for a great number of survivors, life becomes an uphill battle with permanent deficits and complications. Patients should be carefully evaluated regarding the predictions of their outcome, and the predictions of poor outcome is all these things that you can see. Prophylactic antibiotic therapy is very important, and also prophylactic anticonvulsant therapy are used in these cases as well. Many times we have also combination of cerebral and craniofacial injuries during to gunshot, and this is also an important topic to mention. This is how we can manage from the literature the traumatic brain injuries due to gunshot and the normal conditions of the patients. And a small mention of history. Who does not know the history, does not knows the past, and does not respect the present, has no future. This is the first documented, according to mythology, operation that King Zeus suffered from headaches, and King Hephaestus hit him in his head, and got Athena born from the head of his father Zeus. This is the first documented neurosurgical operation according to the Greek mythology. The neurosurgical process and the neurosurgical outcome has been changed due to artificial intelligence. This is the main aspect from Hippocrates to Harvey Cushing, the modern father of neurosurgery, and now that the robotics and the artificial intelligence are coming in everyday practice. This is Alexander the Great and his teacher Aristotle. And Alexander the Great say that I owe my life to my parents, but my good life to my teacher, and we have always respect our teachers in life and also in medicine art. Thank you very much for this kind invitation. It is a great pleasure to be here, and I want to congratulate with the organization about this very nice webinar, and hope to see all of you also in future. Thank you very much, and good luck in this nice event.
Thank you so much. Thank you so much, Dr. Nicholas, for the beautiful presentation. So we'll have the questioning round after a few minutes. So I would like to ask Dr. Saif Anmar from Iraq. You are the second speaker. Are you free to continue your talk now?
Yes, thank you.
Okay, please.
Our topic today is about colloid cyst. I am Dr. Saif Almar from Iraq University. The title is about third ventricular colloid cyst, a new surgical classification. These photos about our team, and Dr. Ahmed Adnan is the chief head of our team. Also our colleague, my friends, Dr. Ali Sabah and Dr. Ali Akram. Yes. A new surgical classification is based on anatomical location of the colloid cyst. Knowing this issue is very important to avoid unexpected findings during surgery. These unexpected findings are, first, no colloid cyst found during surgery. The second one, a closed or absent foramen of Morrow. That is the unusual finding. Of course, this subject published in the World Neurosurgery, an American journal, in 2024. As you know, this is the colloid cyst. That is a congenital mucoid cyst discovered by Wallman at 1858 and is located at the roof of the third ventricle near the foramen of Morrow. This is the foramen of Morrow that is surrounded by the fornix and is a very important landmark during ventricular surgery, and it represents a normal connection between the lateral and third ventricle, as you know. Yes. Colloid cyst is rather rare and can be asymptomatic, discovered incidentally, or may be symptomatic, mostly presented with headache or other features of raised intracranial pressure. Sometimes sudden coma may appear, especially if there is an impaction of the colloid cyst in the foramen of Morrow or a rupture with ventriculitis, or even hemorrhage within the cyst. Of course, CT scan, MRI are the standard tools for diagnosis, and only symptomatic cases are surgical candidates for management. We have many options in the management of colloid cyst. We have an endoscopic way, we have a microscopic way, we have a stereotactic aspiration, and we have observation. Right. Our school in the management is the microscopic approach. Of course, interhemispheric transcallosal microscopic resection. This is the normal foramen of Morrow with the septal vein, thalamostriate vein, choroid plexus that can be found during surgery. And the normal or the expected finding is to find the colloid cyst at the foramen of Morrow, right? The unexpected finding is the foramen of Morrow is closed or not even seen, or there is no colloid cyst. These are very important issues to be kept in mind in order not to be surprised and to continue the right way of surgical resection. This is the normal ventricular anatomy. As you know, we have two lateral ventricles, two foramen of Morrow, opening at the third ventricle, and through the third ventricle, through the aqueduct of Sylvius, to the fourth ventricle. We have 59 cases over more than 10 years. Mostly male were affected with colloid cyst. They were operated on with transcallosal approach, as I said, in a supine position here in Iraq, in Baghdad, in Dr. Saad al-Witri Hospital, in a supine position with the head fixed with a smart head fixation using Sujita system, sometimes Mayfield, with a neutral supine position, with an incision about 8 centimeter exactly over the coronal suture, 2/3 of the incision to the right, 1/3 of the incision to the left, or vice versa, if you are approaching to the left ventricle, with application of the whole system of Sujita, opening the incision, you will find the bone, creating a craniotomy about 3 by 4 centimeter, elevating the bone flap, reaching the dura, creating a dural incision, then reflecting the dura toward the superior sagittal sinus, and insinuate gradually within the interhemispheric fissure, reaching the level of callosum margin artery, then marching forward, reaching the corpus callosum in between the two pericallosal arteries. Opening of the corpus callosum, this will guide you to the ventricular cavity. Of course, you have to have many options. You may have Sujita 1, Sujita 2, Mayfield system with the high-speed drill, with the proper micro tools, bipolar, irrigating bipolar, suction controls of great value, and special type of suckers. That's called Fukushima design, Japanese design. Here we have 4 options of colloid cyst. About 50% of the cases called open Morrow type. You will find the foramen of Morrow, sorry, and the colloid cyst. The second option, about 25%, closed Morrow type. The foramen of Morrow is closed, and there is no colloid cyst. The third option, called retroforaminal type of colloid cyst, you find the foramen of Morrow open, normal, with no colloid cyst. And lastly is the interfornicial type, that the colloid cyst is located between the two fornices, exactly at the midline. You can see that the surprising image is about 50%. I mean the interfornicial, retroforaminal, and the closed Morrow type. Here, these figures illustrate the exact position of the colloid cyst. Here, you have a closed or open Morrow type. I mean the colloid cyst located at the foramen of Morrow. Then we have the retroforaminal, when the colloid cyst exactly behind the foramen of Morrow, we called it immediate retroforaminal, or far away posteriorly, we named it as a distant retroforaminal type. And the photo to the right lower is the interfornicial one. These are magnified diagrams to illustrate open close mirror, interfornicial one, right? Immediate retroforaminal and distant radioforaminal within the third ventricle. Immediate, immediately behind the foramen mirror. Distant, far away posteriorly within the third ventricle. This is the open mirror type. You can see the foramen of Monro and the colloid cyst, and you can start resection through coagulation of the cyst, wall, then aspiration of the contents, then gradual resection of the cyst wall till the end. This is the closed Monro type. You can see no Monro, no colloid, and you have to search for a slit that represent what remained from the open Monro, from the Monro, and you can just try to open it in order to see the colloid cyst, closed Monro type. The retroforaminal seems to be a normal ventricular anatomy. We have, as I said, immediate and distant. Here you have to see the colloid through what? Through opening of the choroid, transchoroidal approach, right? When you open the choroidal fissure through thalamo, through these fissures, you can see the colloid and complete its resection. And this MRI is a special one that can guide you to the type representing the interfornicial one. Also, the MRI can help you in diagnosing the distant retroforaminal, and by time or by this MRI, you can change the approach for surgical resection. Instead of transcallosal type for open Monro, closed Monro, immediate retroforaminal to this type. We name, it is well known as a posterior interhemispheric approach that's done with the patient in a park bench position with this incision just lateral to the midline, 1 centimeter, in a length of 9 centimeter. Then opening the field till you reach the quadrigeminal system, then after to the posterior third ventricular cavity. This is a post-op image. This is the craniotomy photo. This is the colloid cyst. Another colloid. And the message from this lecture is to keep in mind that the cyst can be seen at the level of foramen Monro or cannot be seen at the foramen Monro, and you have to have
Hey, excuse me, doctor.
surgical scenario.
Excuse me, doctor.
Yes, thank you.
Can you go back to the last slide, please? Dr. Anwar, could you go
Yeah.
back to the last slide, please?
The last one, the last what?
Yes, the last slide, please.
Yes.
Thank you, thank you.
Let me help you. Sorry.
Just the last slide, please.
Yes, I will try.
Yeah, just the last slide, please.
He's trying. It's just, I think, loading on his end.
Oh, okay, okay. I was just wondering if we could go to the last
This
slide.
one?
Yeah.
No, the one after that. Yep, that one, that one. 1 second, I would like to take a photo of that, if that's okay with you guys.
Okay.
What are you doing with that photo, if you don't mind me asking?
Sorry.
Oh, I was wondering what the other guy, what he is doing with that photo.
Oh, I just need it for my neurological projects because I have a presentation coming up, and I would just like to present Dr. Anwar's findings or Anmar's findings. Excuse my language.
Oh,
Hey, Dr. Anwar, is this your brain in these photos?
oh my.
You
Sorry,
bald
I can't.
fuck.
Are you hearing me?
Am I what?
Yes. I put these slides in order
Hey,
to, as a collection,
Renato Kishi.
simple collection of
Hey,
colloid.
Mr. Renato Kishi.
Yeah.
Why are you so serious, buddy? Lighten up. Holy moly. Look like somebody died over there. You okay? Buddy's fucking downing or some shit. Yo, buddy, you okay? Pop a couple brewskis, pop a couple cold ones, eh? Dr. Anmar. Come on.
Okay.
Dr. Anmar. Yes.
Sir, can we like keep your mic muted. Let's just keep going with the
Can we hurry
presentation.
this shit up?
No, hey, there's some people here actually trying to do something serious. So if you're not going to be serious, I would just suggest you leave the
Hey,
meeting.
Marcus, no cameras. Marcus, no cameras. Please turn your camera off. No cameras, sorry.
No camera?
Please turn your camera. No cameras. Hey, mute up. Mr. Anwar, mute, please. No microphones.
Sir, doctor.
Doctor, could you mute your mic, please? We have no microphone policy in this class. Thank you. All right, class, let's get back to the slideshow. So what this slide basically demonstrates is that the neurological components of the brain itself, it's not translated from brain A, but you can see in brain B, those receptacles highlighted, those are the parts of the brain that makes a person horny. Now let's go to brain C. Brain C looks like Anmar's brain because it's just fucking empty, right? It looks like there's nothing in there.
Hey,
Got
hey,
what?
leave the meeting now. I'm
Excuse
not
me?
going to tolerate this disrespect, you fucking jackass.
Excuse me?
Leave the meeting now.
Excuse me? Well, what did you say to me? Hey, Marcus, turn your camera off, please. No cameras. Hey, could we get the cholo in the meeting to turn his camera off? Thanks.
You really want me to fuck you in your ear right now if you say another word. Stay muted.
Hey, Dr.
Hello,
Anwar, no
what's
cameras,
going
please.
on? Could you help me to remove that unknown
Could
entry
you
of that
help me
folder?
to get the virus out of the computer? Bloody banchod.
I think
Banchod.
we should reschedule this meeting. There seems to be a lot of unserious behavior coming out of this call.
Yeah,
I'd
I think
suggest
we just need to
hey,
incinerate you
you're the
from the
one who's
vibe.
being
Hey, Jeffrey, I'll obliterate you, buddy. Where you from? Hey, pal? Hey, Renato, are you still here? Renato Kishi, still here?
Oh, I'm here.
Hey, please turn your camera on. Good boy. Thank you. Do you want to continue with the presentation or should I?
Me?
Yeah, just take over for us. Thanks, bud. Please
I
explain this slideshow to the best of your capabilities. And we can get started.
okay.
All right. Whenever you're ready. And no AI, please, no ChatGPT, nothing like that.
Let me see here.
Thank you very much.
I can't. Other people is compart. I can't compartment show my presentation. You must close your presentation, doctors Anmar.
Yes, I finished.
Dr. Anmar, yeah, you should close your presentation.
Yes, closed.
Okay.
Hello, greetings to everyone. I just joined to the meeting right now. Allow me to introduce myself. I'm Dr. Damien from
Man,
Clinical
shut the fuck
Neurosurgeon.
up.
I just want to congrats Dr. Amato for the wonderful presentation. I think it was very interesting. Um, uh, the cases was very good cases. So nice presentation.
Okay. Can you see my presentation?
Yes.
Okay. Good morning. It's a privilege to stand before you, trace the technical and conceptual. I would start with a historical trajectory of pituitary surgery journey. It's an article of Paris Lotz and Abenza Abduya in 2020. In pre-surgical era, the pituitary gland exists primarily as a speculative functional entity rather than surgical target. For centuries, the medical community was theorized the Tugaleni concepts. The pituitary exists only to secrete in mucus. After 1,000 years, the pituitary surgery arrived in the late 19th century throughout the intracranial route to see the hypophyseal functions, growth hormone, TSH, FSH, ACTH, prolactin, oxytocin, vasopressin. But in the beginning, it's too jungle surgery. But before it, you use the transnasal access only for embalming, not for treatment. In the 19th century, a subfrontal access was made at the first time after description of the disease for French Pierre-Marie Tooth, who made the description of acromegaly. A pivotal transition occurred between 1907 and 1910 with the birth of the sphenoidal approach. The landmark moment came into 1907 when Schoeffer performed the first successful transsphenoidal resection. His initial superior nasal or transethmoidal route was by modern standard quite mutilating, yet it proved that the cella could be reached without traversing intracranial space. And this approach was rapidly refined by Oscar Hirsch and most famously by Harvard Cushing. Cushing early work in the corridor demonstrated a dramatic reduction in surgical mortality, prioritizing direct extracerebral routes to Selaturska and chiasma region. This access approach for transfacial, transnasal, sublabial gingival incision, or purely endonasal transseptal approach. While transsphenoidal route flourished during Golden Age, led by Cushing, the field withdrew a paradoxical retreat by 1912. Cushing himself, despite this early success with the transsphenoidal approach, eventually returned to the transcranial route. Despite Cushing's school, Norman Dott and Oscar Hirsch kept studying and improving endonasal route. In the mid-20th century, heralds the renaissance of pituitary surgery catalyzed the introduction of the surgical microscope, building the working Norman Dott and Gerald Julius Hard revolutionized the field by integrating microscopy with the transsphenoidal route. Use the antibiotics, corticosteroids, and intraoperative fluoroscopy reduce the risk described by Cushing. The microscope era permitted the visualized microscopic lesion, not only macroscopic resections. Microadenectomy, the ability to identify and excise the microadenoma while meticulously preserving the normal gland. The visibility, the introduction of coaxial light and binocular magnification allowed for unprecedented clarity within the deep, narrow surgical corridor. And for the first time, surgeons could differentiate the texture and the color of adenoma from healthy adenohypophysis, allowing functional preservation. It enhanced the control near the cavernous sinus boundaries and the diaphragm cellar, significant reduced incidence of neurovascular injury and cephalospinal fluid rhinorrhea. Today, we find ourselves the most endoscopic revolution. The view by microscope, it's a revolutionary vision in middle of 19th century, but can be improved the view to the endoscopic surgery. And you can see here a view of a vision in microscope And here in the endoscope, you can introduce tract to see close or far from your target of view. You have a panoramic angle, a tip intensely bright inside the cavity, mononostril access, no speculum tissue sparing, and expanded approach to paracellular and supracellular regions. This is a view of internal carotid, which made probably everybody afraid to have an accident with carotid. I have one in my career. It's not really not good. And the evolution of pituitary surgery is a history of persistence of human students and the professionals. We not a revolution. It's a study and a study and a study along the last century. After this brief historical introduction, I would like to show the security parameters. Pituitary surgery is a delicate balance of precision and anatomical mastery. We will focus on the anatomy, various surgical approach, and the critical strategies for risk mitigation in the paracellular risk. This begins with the topographical mapping and the preoperative imaging, followed by rigorous selection of approach based on diagnostic matrices. We then move into the execution of the surgical corridor via transsphenoidal techniques, and finally focus on the preservation of function and the complication management during recovery. The modern surgical journey follows a rigorous four-stage chronological workflow. The pre-operative navigation, where we identify anatomical traps, cellular access, intraoperative resection, and the post-operative management. The approach selection is our primary tools for risk mitigation, while the transnasal approach is our primary mainstay for standard adenomas with normal vascular spacing. Approximately 10% of cases require transcranial approach. Why? Because the firm and fibrotic tumors, sometimes the vascular anatomy prohibit the transsphenoidal approach, and we have some complication, brain retraction injury, and neurocognitive deficits for transcranial approach. One of the most dangerous anatomic deception is Onodi variant in standard anatomy. The optic nerve is protected superiorly. However, Onodi cells posterior ethmoid expansion laterally displace the optic nerve. If the variant is not identified preoperatively, it invites a blind transection during sinus opening. We must never proceed without confirming the lateral position of the optic nerve in relation to the ethmoid cells. During the resection phase, we must understand that neural tissue can be destroyed without ever being touched. If you compress it, you can have a lesion by crush mechanism. coagulation, microcoagulation, share the blood supplies, and over cauterize and make microvessels can starve the optic apparatus. Significant visual loss occurs through the ischemic devascularization, even with zero mechanical contact with the optical apparatus. Success in cellular surgery requires a three-dimensional understanding of the supracellular compartment, the anterior, the arachnoid membrane of the chiasmic cistern, the superior limit, the optic chiasma, and the floor of
Sorry
third.
for the interruption, Dr. Renato.
What?
Sorry for the interruption. Uh, I I have made you the host, for which I have removed by the host. Could you make me host again so that I can admit the other persons who are waiting in the waiting room? Some of our speakers are waiting.
Okay, didn't understand.
Okay. You make me host.
Make me?
Event host. I have made you the event host. So you need to make me the host again.
You made her as a host.
Yeah. For which I have lost my host. So that's why he need to make me the host again so that I can control the event.
You couldn't see.
No,
He
code.
need
You need to go to the more button and you need to go to participants and you need to make host to Gitanjali Rao. Okay.
Yeah,
I think you didn't understood.
need the host. Keep it. I'll keep talking. Okay?
Uh, no. Try to understand me. You go to your participant list and make me the host.
I
Could the other speakers I request, could you please tell him what to do? I think my conversation is not understandable.
Dear Renato, go to the icon of participants in the line below.
what you can't see.
So you can make her as a host of the event. Now you are the host. She need to be the host.
Conseguiu, Renato? Embaixo tem participantes, 11 participantes. Você clica lá. Quando você clicar, você vai selecionar Gent Jali e adicionar ela como anfitriã.
Oh, thank you, Dr. Marcus. You really saved me with your language.
Of course.
Getanjali how?
Yeah. Gentajali Hall.
Okay.
Okay. Thank you. You can continue now. Thank you. That's very great. Thank you so much. Sorry for the interruption.
Can I keep it talking?
Yes. Please.
So the anatomy dictates the surgical corridors. we must account three Burgundy scenario regarding chiasma optic position. A prefixed chiasma overlies the tubercle cellar and restrict anterior access, often necessary transcranial approach. The normal chiasm rests over the diaphragma cellar, while post-fixed chiasm and a wide favorable anterior corridor between the optic nerves. Okay. How to calculating the sphenoidal safety window? When planning a sphenoidal route, we must calculate the safety window. This and the depth of the cell, average 46 millimeter. It's a critical inside here that his surgical area is significantly smaller in females compared to males, which can increase surgical difficulty despite the higher prevalence of female adenomas. This is a close safety windows, but we always should secure and not more too difficult. The sphenoidal plan can have different anatomies to difficult to centralize your access, surgical access. The cellular barrier, one of the primary goals, is predicting the prevent cerebral spinal fluid leaks. We classify the cellular barrier into three types: a strong barrier, dura gland more than 1 millimeter thick, provides a protective shield; a mixed barrier offers a partial shield; and a weak barrier, arachnoid only, less than 1 millimeter thick, has a near 100% correlation with intraoperative cephalospinal fluid. When you have I forget what a thick, always in my service we usually make a rotation of the mucosa, nasal mucosa. Why we reserve a transcranial subfrontal pterygium route? Absolute indication: kissing carotids, firm fibrotic tumor, prefixed chiasma, circle of Willis encasement, and purely cavernous sinus involvement. The other, all cases, we transsphenoidal access is favorable. We should navigate by corridor. The endoscopic transsphenoidal execution occurs in three distinct phases. Phase 1, nasal, involves widening and medial corridor. Phase 2, sphenoid focus on remove septation and identifying the optic carotic axis. And finally, phase 3, cellular, involves opening the dura and facilitating the delivery of the tumor. The efficiency of operating room is maintained through the optimal ergonomics surgeon. And the osteodural defect reconstruction, once the tumor is removed, we access the leak. For the microadenomas with strong barriers, simple cellular packings is often sufficient. However, for macroadenomas with weak barriers, we must employ an aggressive multi-layer reconstruction using autologous fat grafts, a semi-solid buttress, and the pedicle nasoseptal flap. Okay? At the end, the surgeon, after closing, and before the finish my presentation, who usually make endoscopic nasal surgery here? Just to put the N for no and the yes for in the chat.
Yes. Yes, we are practicing nasal endoscopic transsphenoidal hypophysectomy for pituitary macroadenoma.
Do you make the endoscope for third ventricular cyst endoscopic too, or not?
No,
No.
just for macroadenoma that can be sometime extending up to the lower part of the third ventricle, but purely third ventricular lesions or other lesions other than pituitary macroadenoma, we don't do it. We are afraid from CSF leak and the fatal outcome after meningitis. And we can't see properly or make safe dissection of the mass from the relevant or nearby neurovascular structures.
Understood. Okay.
I know that some centers making endoscopic transnasal resection of of craniopharyngioma and tuberculum meningioma, but I think it is not so safe as transcranial, for example, lateral supraorbital approach.
Okay, thank you.
Yes.
So I
Thank
will
you
do
too.
presentations next. Can you hear me?
Yes.
Yeah. Okay.
Hello.
So share my screen.
Sorry, I thought I was the next speaker based on the updated schedule. Is it changed again?
Yeah, that's okay. Because some of the speakers were absent, so you can adjust your presentation. If you can wait for an hour, then it's okay. If you have any emergency surgeries, then we would request Dr. Jolitover to for his delay of the presentation. You people, please discuss about that, which will be
So
better.
who will be the next?
If it's okay, I'll finish and I have a small appointment to go to. Is that okay?
Okay, yeah, you can do it.
Yeah, sorry
So,
about that, and thanks for the
No
flexibility.
problem.
Yeah.
that's
No
okay,
problem.
Anupdeep. That's okay, Dr. Anupdeep. Let me share a thing. Dr. Damian Lester Capello is waiting and he was unable to join in this meeting because previously, for some disturbances, I have suddenly blocked 2 to 3 numbers between which his number was there. So, what should be done now? Is there any option for him to join? Do you people have any idea?
No.
Okay. Okay, then I'll try to solve. So, Dr. Anudeep, you please carry on with your presentation. Thank you so much.
Thank you so much. I am Anudeep Ekula. I'm a neurosurgery resident at the University of Minnesota and a research fellow at the Mayo Clinic. I'm currently in the United States. Thank you so much for giving me this opportunity to present. I know all of you are talking about how to do surgery. I'm talking about the opposite thing. So, how to avoid surgery. So, that's where the concept of liquid biopsy comes into the picture. These are my disclosures. We are all very familiar with the paradigm of management of gliomas or most brain tumors. A patient comes with a symptom, then we do an image, such as an MRI, and then find a lesion. And then we take the patient to the operating room and either do a biopsy or a resection. And if it's a glioma, the patient undergoes chemoradiation, and then we continue to monitor the patient over the course of his lifespan using serial MRIs. And we know that the tumor usually comes back. There might be treatment-related changes from radiation effects, such as pseudoprogression or radiation necrosis. Surgery is highly invasive. Biopsy can result in life-threatening complications. And when the tumors are very close to the functional location or difficult to access locations, the biopsy can be challenging, resulting in neurological deficits. And we know that a single biopsy might not capture the entire picture of the tumor. It's not possible to do multiple biopsies along the course of therapy. And we know that these tumors always change with time and therapy. And imaging-based monitoring that we often do not provide insights into how the tumor is changing over time. Can we change this? What if there's a blood test that helps us diagnose a brain tumor? What if there's a blood test that can stratify patients to an appropriate therapy? What if there's a blood test that can monitor the response to therapy? And what if there's a blood test that can monitor for recurrence? And that's where the concept of liquid biopsy comes in. Liquid biopsy involves study of blood or CSF or other bodily fluids to detect tumor-derived material. There are three areas of interest in liquid biopsy: circulating tumor cells, cell-free fraction, and extracellular vesicle fraction. I'll briefly talk about these and give a few examples of how liquid biopsy is changing the landscape of how we can diagnose a brain tumor. It's recently found out that the tumors release some cells into the blood or into cerebrospinal fluid. If we are able to capture these circulating tumor cells, we can figure out what kind of tumor it is. But the problem is that the number of cells released by the tumor into the circulation is very few, and those represent some aggressive subclones of the tumor cells that are able to release from the main tumor and get into the circulation. And if there is intact blood-brain barrier, the tumor cells are unlikely to be released into the blood. And they're very rare, and you need advanced technologies for isolation and characterization of these circulating tumor cells. And then the second part of liquid biopsy fraction is circulating tumor DNA. This is also something that's recently found in the last couple decades. So we know that the tumor sheds DNA material into the bloodstream. When the tumor cells are dying due to different reasons, the cells release these circulating tumor DNA into the blood. And if we're able to capture this DNA and study the mutations, we might be able to figure out what kind of tumor it is. But the problem is that the circulating tumor DNA is very fragmented, and it's hard to get a full picture of the tumor just by studying this. And thirdly, extracellular vesicles. These are the small membrane-bound vesicles that are released by the tumor cells into the bloodstream. When these are budding off of the tumor, they take with them microRNAs, mRNAs, and proteins from the tumor cell and make their way into blood. The good thing about extracellular vesicles is that they have membranes. So whatever content they have inside them is stable. So if we're able to isolate these vesicles and study the material inside them, we might be able to characterize the tumor. These are like very recent concepts, and I want to give a few examples of how we were able to use these technologies to push the boundary of brain tumor diagnosis. And first concept I want to talk about is 5-ALA-based liquid biopsy. The reason why I'm bringing this up is to improve biomarker sensitivity. We're all familiar with 5-ALA. The patient takes 5-ALA before the surgery, and when we go into the operating room under blue light microscopy, we know that the tumor shines pink. And as neurosurgeons, we try to take out all the pink portion of the tumor. The question that we asked is, if the tumor is glowing, will the extracellular vesicles released by the tumor also glow? And the mechanism is there is alteration in heme synthesis pathway that results in accumulation of protoporphyrin. And that is the component that makes the tumor glow. And this is widely accepted and shown to have improvement in surgical resection. So we developed a pathway to isolate these fluorescent vesicles released by the fluorescent tumor. We used advanced technologies to count these vesicles, and we showed that when you treat glioma cells with 5-ALA, they release fluorescent vesicles. When you treat mice with tumors with 5-ALA, they release fluorescent vesicles that we can pick up in their blood. And when we looked at some patients who had fluorescent tumors at the time of surgery had higher 5-ALA EV signature in the plasma. So in this paper, we were able to show that the tumors in fact release fluorescent vesicles into the blood. Then we used nanofax to sort and then use sequencing methods to study the contents in these fluorescent vesicles. And then we showed that these fluorescent vesicles have tumor-related RNA that can kind of tell us that it has some neural origin and that it's coming from the brain tissue. So we are optimizing these methods to kind of pick up tumor-related genetics. So this way, we can maybe diagnose a brain tumor by looking at the fluorescent signal in blood. And we showed that there are several genes which are important in tumorogenic pathways that we can pick up in these fluorescent vesicles. These are our papers where we talked about these methods. Another application that I will talk about is studying extrasomal RNA as a way to stratify patients to appropriate therapy, as well as to monitor the response to therapy. We had a clinical trial where we studied the effect of the drug dacomitinib, which is a EGFR V3 inhibitor in patients with recurrent glioblastoma. Like all the clinical trials in glioblastoma, it is a failed clinical trial, but there were 8 patients who responded to therapy and 48 patients who did not respond to therapy. So we took 7 responders out of the 8 and then 7 non-responders and studied plasma RNA signature. So we isolated the exosomes, looked at their RNA, and did sequencing to study what RNA profiles they had. And these are the baseline characteristics. So both the cohorts are pretty similar. And we showed that the plasma of glioblastoma patients is quite different from healthy patients. So we know that this RNA is released into the blood, and then there is a difference in the signatures that we see in the blood. And these RNA are important in gliogenesis, regulation of apoptosis, immune regulation, metabolic remodeling. So we know that a lot of these RNA are involved in several tumorigenic pathways. And then we looked into what these RNA are. And then when you look at the plasma prior to treatment, there is also a differential signature. And we saw that these two genes will allow us to predict who might respond to this dacomitinib therapy. And when we looked at the plasma of these patients post-treatment, we saw many differences as well. For example, this RNA is enriched in responders, which can give us a sense that the patient is responding to therapy. So to simplify, we developed methods to say that if we look at plasma RNA signatures, we might be able to predict who will respond to a particular therapy. And by studying RNA signature in blood, we might be able to predict what that response is as well. This is the paper that explains that. And the last example that I want to talk about is this digital droplet PCR assay that we developed to pick up TERT promoter mutations in plasma. We all know that TERT is a very important mutation in the context of gliomas. And if a patient has a TERT promoter positive glioma, they tend to do worse. So we developed a blood test that can pick up this mutation in plasma. So similar to what we talked about, we take a ml of blood, we isolate cell-free DNA in this context, and then run that blood test, and then figure out if the person has a TERT promoter mutation. So we are trying to diagnose the tumor, if it is TERT positive or not, just by a sample of blood. We've optimized it and used some advanced methods to develop this assay. So we had a large cohort of 83 patients in our discovery and a validation cohort of 74 patients. We had TERT mutant gliomas, TERT wild-type gliomas, some healthy controls, and other non-tumor controls. And we showed that we are able to pick up the TERT promoter mutations compared to everything else. And we were able to achieve a sensitivity of 62% and a specificity of 90%. So it was a quite good test. And we also showed that along the course of the therapy, if the tumor is coming back, the levels of TERT promoter mutations increased in blood. But if the patient had stable disease, the levels of TERT promoter mutations remained stable. So essentially, this is the blood test that can pick up specific mutations. So over the course of the last 10 years, our group was able to figure out ways to study blood and figure out what kind of tumor it is. And of course, this is at the initial stages, but this is promising. And hopefully one day we will be able to have a blood test for brain tumors, just like we have a blood test for diabetes or other diseases. I will stop sharing and take questions if there are any.
Very nice topic. Thank you for good results. But do you use this labo tests routinely in your daily practice or just experimental work?
As of now, they're still in the experimental phase, and we are optimizing things so that we can get things to the clinic. The other new test that we are developing is IDH mutation test. Again, we know how IDH mutation is super important in gliomas, and there are also these IDH inhibitors that are coming up. So, we are still working on getting them to clinic. We're not there yet.
Yeah. Very promising results, and
Mhm.
hopefully we'll use it in the future as we'll
Yes.
diagnose diabetes and so on.
Yeah.
Nice.
Hopefully I can make all of us jobless.
Yeah. It's not a good idea. Not.
That's a
Yeah.
joke. Thank you
Yeah.
so much.
Okay, thank you. So I will continue.
Thank you. Yes.
Yeah, Dr. Jolotov, you can continue. After
Okay.
your presentation, Dr. Marcus will give. Okay.
Yeah. So, as I introduced me, I'm a neurosurgeon, but mostly I'm working in a spinal department, and we specialized on robotic surgery and endoscopic surgery. So I try to make my presentation quicker, and if you don't mind, I have a small results of our endoscopic study, and I added on the end. So why is robotic? So if you treat a difficult cases, patient with scoliotic or degenerative changes, it's sometimes difficult to put the screw correctly. So we was able to buy a robot from Medtronic, and I want to share you our results since last 5 years. Spine assistancy has its own history. It was begun in 2004. The company Mazor from Israel developed some kind of device which wasn't a robot, but it was assistant, and you can put it on the spinal process and create a trajectory for your screws. It was very time consuming, and it was not able to be involved in the operative practice. So they developed the second edition in 2011, and in 2016, Medtronic, the big company, bought it and developed its own robot. It was already a robot. They combine navigation system with this device from Israel company. And in 2019, they developed the second edition. It calls Mazor Stealth, which we have an opportunity to use in our department. So it's how it looks. And sorry. Yeah. It has its own navigation system, and it's a walk-in station. It consists of small monitor, which we used, so surgeon can use it intraoperatively, and it's a walk-in arm. The next month, they have already a new system, so we will get the system next month, and we can try and compare these two new systems in our department. It's more mobile system, and you don't need to fix it on the table and on the patient. So what we do know about robotic spine surgery until now, the literature review shows us that there are a lot of studies until now, and every study showed us that there is significant higher perfection of pedicle screw insertion in robotic surgery, and less proximal facet joint violation in comparison to hands-free technique, less hardware failure revision surgeries, and wound infection, also less neurological deficits in comparison to hands-free technique. It was shown in 8 studies. Of course, significantly reduced radiation time and doses in comparison to hands-free technique, and it's a huge advantage as I can compare these two techniques for the surgeon for else. Then it also noticed that significantly increased of length of the operation, so you can do the operation faster, and to comparison in free hands technique. Also, it's usable and has its advantages in minimal invasive surgery. Also showed here. Also, what was noticed that the use robotic surgery have more advantages when you use it in case when you have to put more than 4 screws. It's also our experience, because to put the robot, to fix it, to make the scan and so on, it's very time consuming procedure. So if you have less than 4 screws, so it's give you no advantages according to the hands-free technique. So nowadays we use it in very complex cases when we have to put more than 4 screws. But it has its own disadvantages, because it's a higher tool, higher cost of this tool, and until now we use it routinely to make it cost a little bit less. So we use it in more patients as possibly in more difficult cases, and it gave us advantages and give us possibility to lower the price for the operation for the hospital, I mean. And of course, a learning curve, and you have to train your staff to use the robot. It also time consuming. So a few words about workflow. At the beginning, you have to plan your screw trajectory. Then interoperatively, if you do it preoperatively. Interoperatively, you have to mount the robot on the patient, to fix it on the patient, then make a 3D scan, make snapshots, and define in your surgical area. All the time you have to control the robot, but usually it works properly, and very, very rare it has some mistakes in preparing. Then you match your preoperative scans with the intraoperative fluoro shots in AP and oblique view. Then you send the robotic arm to the screw trajectory, drill, tape, and insert the screw. And usually take from me per screw about 4 or 5 minutes, maybe less. It's a software developed from Medtronic. It's how it looks, how you can plan the screw. It's very precise software, so you can put the big screw even if you have a very, very small pedicle. Then you can observe your entire system, measure the rods, and align the screw in a better position to insert the screw without difficulties intraoperatively. How it looks. You can also see the implants, which was introduced before, and involve it in your planning. In difficult scoliosis cases, you can modulate the entire operative field and modulate also your correction after the insertion of the screw and the rods. And the system can say you where you have to make a correction, osteotomies, and so on, which degree you have to use there, and even more. each segment is the system know each segment, and you can modulate it and put on the top and play before the operation with deformity cases, I mean. So intraoperatively, you fix, so the staff fix the robot on the table. Then we grab the patient and fix the robot, usually on the iliac crest or on the spinal process if you have to operate a thoracic spine area. Then you make snapshots and navigation registration relative to robotic coordinating system. Then you make two X-rays, as I said, in lateral and oblique position, and the system merge these two images to preoperative CT images, and you check all the segment if it fit or not. And then if you agreed and if you are satisfied, you continue, you send your robotic arm to the trajectory and to choose the vertebral level, then drill, tape, and pull the screw. About our experience, so we start in 2021. Until now, we have about 800 cases. We use CT flow, matching workflow, because you can use also intraoperatively arm and make scan intraoperatively, but for us it's less usable, so we use CT flow matching workflow. Mostly we use it for open procedures, but still and until now even more for percutaneous stabilization. For the reference in matching, you need about 25 minutes and 15 to 46. It depends on who you have on the table from the staff and who operates the patient. Time for reference in per screw and to insert in the screw, it's about 3 to 7 minutes. I want to show you some difficult cases. Case number one is a female who fall against iron bar in gym, was presented us after 5 weeks after the adverse event and with a severe back pain. After we did CT scan, we diagnosed H-type fracture of the sacrum. You can see here very unstable. So we decided to do lumbar pelvic fixation L5 to S2 a la ilium screws. It's how our plan looks. You can see L5 S1 and L2 a la ilium screws here. It's intraoperative images. We did it percutaneously with a small incisions, small in every incision for every screw, and how it looks post-operatively. We could mobilize the patient on the first post-operative day, and she was discharged at fifth post-operative day. Second case, old lady with severe adult scoliosis, which was from adolescence with 40 degrees cup angle between 212 until L4. It's a CT scan, very difficult anatomy with lateral shift of the L4 vertebral body, so it would be very challenging for the hands-free technique. So we do several operations. The first operation was anterior release and fusion from L3 to S1. We use a leaf technique to put the screws between the vertebral bodies. And the second was posterior stabilization and correction T9 until ilium. You see the results. The patient was satisfied and was discharged after 1 week after the operation. The third case, it's a revision case. The patient was operated, it's old lady also. She was operated on in another hospital and sent to us to help her. She was initially fused from L3 to S1, but developed infection in L5 S1 level here. It's how it looks previously after the first operation in that hospital, and they revised her and they put 2 iliac screw because actually you have to remove this cage, but when you have the patient who has already a leaf procedure retroperitoneally, so it's sometimes difficult to go again inside. So how it looks when the patient was presented to us, and it was very difficult to find a correct decision how to treat her. You can see here pseudoarthrosis, and that level she was treated with antibiotics before. So we decided to make additional fixation. We revise here only from posteriorly. We remove screws from ilium, put another bigger screw there, and planned with robot additional 2 iliac screw and fix it with 4-rod system. And of course, additionally, we take samples from this cage from posterior and start again antibiotic therapy. And of course, scoliotic patient also will treat a lot of them with robotic assisted surgery. It's a young patient, female with Lenke A1A scoliosis with the Cope angle 58, and how it looks intraoperatively, and here as well as postoperative results. So primary conclusion, we just did it after 60 surgeries. After 60 surgeries, we have passed through the learning curve. So you have your staff and you have make at least 60 surgeries to have smoothly operative procedure. Remarkable progress with workflow and handling. You can do after that screw incision in difficult anatomical situation much easier. And as I said, possible time benefits for surgeries with more than 6 screws. Thank you. I have some question.
Thank you very much, Dr. Jorotovec. This was
Congratulations.
very, very informative.
Okay, thank you. So may I make the second presentation? Do I have still some time?
Yes, we are having 2 to 3 more talks now as they were in their emergencies. After that, you can continue your second topic. Okay?
Okay, yeah, so.
That's okay, great. We request anyone having any questions on this, then they could ask.
Okay, so I continue. It's our small study about comparative outcomes from endoscopic versus microsurgical resection of the synovial cyst in lumbar spine. Disclosure, I have a contractual relationship with RivoSpine, but my presentation reflects my own clinical experience and options. About historical background, endoscopic spine surgery has its own history, and in 1975, Professor Hijikata introduced percutaneous discectomy, laying the foundation for minimal invasive spinal procedures. Subsequent developments by Kabman Jung and Sebastian Rutten expand indication to spinal stenosis and degenerative conditions. Today, full endoscopic interlaminar techniques allow effective decompression with minimal invasive tissue trauma. We use full endoscopic monoportal interlaminar approach with vertebrous lumbar system. Its motorized and manual instruments allow precise bone resection while preserving nerval structure. We use usual oval bore for aggressive forward bone resection and round diamond bore for less aggressive, more precise bone resection around nerval structure. Also, of course, we use normal instruments with adjust for the endoscopy surgery. We use the full endoscopic monoportal interlaminar approach with vertebral system, and it allows us very excellent visualization through the small walking corridor inside the spinal canal. So we use normally 8 millimeter walk-in sleeve and about 6 millimeter walk-in channel. So we can use relatively large instruments. And you can see in this video that how we use this sharp drill to remove the bone structures and the diamond drill for more precise job. The synovial cyst of the facet joint are rare benign lesion that arise from the defect within the facet joint capsule with or without communication with the joint itself. And it's very often causes radiculopathy or neurological deficits. The study representatively examines our comparative results of endoscopical and microsurgical removed lumbar synovial cyst. Study was performed from 2022 until 2026, total 20 patients. The group were comparable and improvements were measured using Oswestry Disability Index to measure the functional outcomes and vision analog scale to compare the pain after the operation. Recent literature has increasingly highlighted the role of endoscopic spinal surgery as less invasive alternative for degenerative lumbar pathology. Several studies have demonstrated that endoscopic techniques allow effective decompression while preserving stabilizing structures and minimizing tissue trauma. Our results are consistent with these findings and support the growing evidence of endoscopic resection as safe and effective option for the treatment of lumbar synovial cyst. One of the cases, it's a huge synovial cyst at L4-5 level with compressing L4 and L5 nerves here. Intraoperative video, as I said, firstly we use the sharp oval burr to resect the facet joints. First, at the beginning, you resect inferior facet joint. Then you reach to the SAP superior articular process and remove it. Here I remove the capsule. Then the superior articular process. Then you dissect the capsule from the neural structures, remove it piece by piece with the sharp instruments. You can use even scissors under the visual control to cut the wall. And you can see the nerve root is completely free, and cyst was removed. This is our results. It's a small group of the patient, but you can see the difference. I will say about it now. So the mean follow-up was 10.5 months. Complete resolution of leg pain was achieved in all patients in the endoscopic group, compared with 90 patients in the macrosurgical group. Patients treated endoscopically demonstrated lower postoperative ODI, 4.5 versus 7.2. Shorter operative time, reduced blood loss, and shorter hospital stay. No patient in the endoscopic group developed postoperative mechanical log pain or required fusion, whereas one patient in the macrosurgical group did. So it was the end. Thank you for your attention. Our center, we have a training program for robotic and endoscopic surgery. So if somebody want to visit us, just contact me. This is my contacts. You can find me in the LinkedIn. Thank you. Does somebody have some question?
Yeah, thank you, doctor. If anyone having no questions, then we will move to the next talk. Next talk will be given by Dr. Marcus. Am I
Hello,
correct?
Yeah,
Okay.
good morning. Good morning for all. Let
Please
me
give the
share.
introduction again before starting, because some of our new speakers have joined right now.
Can I begin?
Yes, give your introduction before beginning.
Okay. Sorry. Oh, okay. Let me see here. No, that's stop. Okay. Back of payment Okay.
What you are looking for? Sharing screen.
Yeah, I had some problem to share my. Let me try again.
Do I need to?
Okay. No, I think, yeah.
Okay.
Can you see? Yeah. Okay.
Okay, fine.
Okay. Okay. Good morning. My name is Marcos Vinicius Brito Marques. I'm from Brazil. First of all, I would like to thank the entire organization of this event. Thank you for this opportunity. Okay. And I will say a little bit about lumbar uniportal endoscopic surgery. I declare no conflict of interest regarding this presentation. All patients sign a consent form for the display of images. Okay. What is the gold standard? What are the advantages and the disadvantages? Today, we're going to discuss the current gold standard, compare its advantages and disadvantages with alternative techniques, and review the learning curve associated with each of them. So here we have several articles comparing different techniques in attempt to know which technique would be best recommended for each case. But microscopic discectomy continues to be the gold standard. Current evidence shows that neither technique is clearly superior. The choice depends on the pathology, the surgeon experience, and the patient's needs. In general, the uniportal technique may reduce operative time, whereas the biportal approach offers a shorter learning curve and less radiation exposure. So we have inspiration, invention, and innovation. So what we practice today and build today is based on what we learned from our teachers. Just a historical contribution to endoscopy. Parvis Camping in 1973, using and performing the percutaneous nucleotomy, and in 1986, using cannulas with 5 millimeters diameter, and in 1988, first endoscopic image of herniated disc, and 1990 described as the safety triangle. Okay. Thomas Hogland and Michael Schubert in 2005, they performed the first transforaminal endoscopic procedure, removing an extruded fragment by using burrs and expand the foraminal window and remove the ventral aspect of superior articular process. Here, Kevin Foley in 1999 published their experience with the extreme lateral approach for L3, L4, and L4, L5 disc herniations using 25 degrees lens endoscopes and a 16 millimeters diameter expandable tubular system. And 2000, here, Sebastian Rutten described the uniportal interlaminar endoscope approach, and Anthony Young developed the first full function multi-channel endoscope discectomy system with a 7 millimeters diameter and compatible instruments. Okay, here are some instruments for endoscopy. It is always important to pay attention to the length of the instruments and relate to the length of the optics used. Okay, for here the transforaminal optical, forceps dilator, cannulas, the instrumentals, and the patient and the rule position, the tower and its components, camera, light. Okay, understand your patient first. Okay, make a good anamnesis, a good physical examination, inspection, palpation, special tests and maneuvers, application of pain scales, pain classification, and validated disability index. The scales to know about the intense of the pain of the patient, mild, moderate, severe, topography of pain, and stratification using 0 to 10 scale. And it's important to know if the pain is an axial pain or a radicular pain or the two kinds of pain. Okay. I use normally Ulster Disability Index in my surgeries. It's important supplementary examinations like standing function radiographs and evaluated spondylotic chains, iliac crest high, presence of enlarged transverse process or transitional vertebral, spondylolisthesis, size of bone windows, evaluate for signs of instability. Okay, and um, using MRI, lumbar, spine CT, and CT myelography. Nowadays, I don't use CT myelography. Um, Using 8 bearing function radiographs, it is important to evaluate the instability criteria in the lumbar spine. Segmental kyphosis larger than 11 degrees, listas greater than 3.5 millimeters. Okay, here we can graduate it. And addition exams. MRI, it's important to evaluate the spondylodisc arthrosis, herniations, locations, and migrations, facet joint orientation, synovial cysts, ligamentous thickening, anatomic variation of neuroaxis, vertebral canal area. Okay, here we have in the left an article, American Journal Neuroradiology, and visualization of a synovial cyst of 8 bearing MRI provided additional information that influenced decision making, okay, in this case. Um, in in this article, Spine Journal, axial weight bearing MRI demonstrate a significant higher degree of listhesis than conventional MRI. The degree of listhesis showed a stronger correlation of weight bearing MRI compared to stand radiographs. Okay. Okay, TC, to evaluate hernia or ligamentous calcifications, detailed assessment of osteophytes, presence of spondylosis, evaluation of bone defects, prior instrument arthrodescence, signs of looseness of prior implants. So where do we start with pathway? At this point, what's most important is to choose the technique you know best, the one with which you have the greatest knowledge and experience, okay? To know if you will choose an interlaminar approach or a transformational approach, okay? Here, looking for the window, okay, the position, the target point, planning your target using wire Kirchner, okay? So the steps for interlaminar endoscopic lumbar discectomy. Now use the burr. We're going to see an example of a case, a simple case that I used interlaminar, okay, like this. For 8 years old family, progressive left L5 S1 radiculopathy after failed conservative treatment and prior percutaneous lumbar procedure with worsening pain, motor depth, and function disability, OS3 and 50%. Intervention, short improvement after infiltration in lumbar spine on March 10, 2026. On physical exam, uh, we saw antalgic gait, positive left, straight left raise, dermato hypoesthesia, left ankle dorsiflexion, MRC 3/5, left extensor hallucis longus, MRC 3/5. Okay. this is the case. The axillary, no fragments of hernias. And the discectomy done. It's a great pleasure to do this kind of surgery because we can take an excellent look for everything. Okay, and transforaminal endoscopic lumbar discectomy. These are the steps. Okay, the Camping triangle. Okay, with which vehicle that you're going to use is not important because you can use all of them, okay, and reach in your distance. So, planning the preoperative, which roads, transforaminal, using posterolateral, extraforaminal, extremolateral, or bilateral. And interlaminar, you can do translaminar, transfacet, transpedicular, over the top, or contralateral. Okay, another case, a 46 years old male, NAT professional, 2 years history of axial pain, VAS, and 5, initially improving with physical therapy and medication, with OS3 and 30%. The intervention recurrence of axial pain combined with left L5 radicular pain, VAS 8, nearly 1 year ago, with subsequent failure of conservative treatments. Now, with OS3 and 54%. On physical exam, hyperesthesia on the lateral aspect of the left leg, positive left side lasag sign. Okay, his pain, radicular pain, it was 8. Okay, these are the radiographs, no instability. This is a lumbar spine MRI in 2022. This is another 2 years in 2024. We can see a lot of thing that was doing. Okay, this is the sagittal and the axial. Can see. So I decided to do a transforaminal access, and I saw a facet, cyst facet, and L4, L5 that was compressing the L5 nerve root left. So I was surprised. So I take it all. And I burn it, the rest. This is the end. Moving the nerve root. I decided to don't make a discectomy in this case, and the patient. So this is the microscopic features of synovial cyst. Okay, confirm it, and the patient very good after this surgery. Okay, now extreme lateral access. It's the view of the extreme lateral access. Okay, normally used in L4, L5. This is another case, a 6-7 years old family, and as active stent, 1 year history of radicular pain, refractory to physical therapy and medication, over 50%. She underwent left L4, L5 foramen injection 8 months ago, with subsequent clinical improvement lasting 2 months, only 2 months, history and 18%. On physical exam, hypoesthesia on the lateral aspect of the left leg and positive left side LZAC sign. Okay. We can reach the other side using this approach. Okay, and let's talk about the over the top. This is the another case, 8-9 years old male, retired, 1 year history of axial pain associated with neurogenic claudication for less than 100 meters, refractory to conservative management with OS3 and 56%. Intervention underwent L, L2, L3, and L3, L4 foramen injections with over 8% pain relief, lasting 2 months only. Okay, on physical exam, hypoesthesia from the knees down was on the right side, positive right side LASAG sign. Okay, this is the radiograph and the MRI. It was my first approach using over the top. It was made in 8/22. And after that, the patient was very great and happy after this kind of surgery. Okay, that's all. Thank you for attention very much.
Oh, that's really
Oh,
very
that's
nice.
really very nice.
I request our all
I request
speakers,
all
if you
speakers,
have any
if
doubts
you
or
have any
questions,
doubts or
you
questions,
can
you
could ask.
could ask.
Dr. Damian, your voice
Dr.
is not.
Damian, your voice is not.
Hello, can you hear me now?
Hello, can you hear me now?
Yes.
Yes.
Yes, but
Yeah.
keep
Yes,
mute
but
another
keep
phone
mute
because
another
there is
phone
no
because there is no.
Okay, so I will
Okay,
try
so I
to.
will try to.
It's better now?
It's better now.
no, the resound we are
No, the
getting.
resound we are getting.
Yes, Dr. Kai,
Yes, Dr. Kai,
it's your turn
it's
now.
your turn now.
Could you hear me?
Yes, yes.
Yes, yes.
And how to upload my PPT?
Okay.
Okay.
You will get
You will
start
get
screen.
screen.
More options.
More options.
You will get
You will
start
get
saving.
start saving.
Yeah, I don't know how to upload my PPT.
Okay, our speakers I
Okay, our
request.
speakers I request.
Okay.
Okay.
Okay, fine.
Okay, fine.
I'm sorry, I can't upload my PowerPoint.
Now we saw again
Now we
it
saw
varies.
again it varies.
It's a problem. I cannot upload my PowerPoint.
Put it try again.
Put it time again.
Could you send the
Could
photo
you
how
send
it's
the
looking?
photo how it's looking?
Yeah, can I send my PowerPoint to you and you to show?
No, you can send
don't
the
have
You
one.
can
screenshot
send the
what you're
screen
looking.
what you're looking.
I sent you my PowerPoint.
What is the time in
What
your
is the
country
time
now?
in your country now?
Time it's about 2 p.m.
Great.
Great.
So I think this is not the Zoom meeting.
This is Zoom meeting
This
only,
is
sir.
Zoom meeting only, sir.
Yeah, I don't know how to upload my
Okay.
PowerPoint.
Okay.
It's not before. It's not happened before. It was not happened
Okay.
before.
Uh,
What you are seeing in
you
the
are
screen,
seeing in
put
the
the
screen, put the
screenshot and send us.
screenshot and send us.
So let me log in again. Okay, just a moment.
Okay. Dr. Damian, if you are talking anything, then please listen. We can't hear your voice totally.
Can you hear me now?
Yes.
So what I'm going to do, I will use the mic of my phone, and I will use the laptop for the presentation. Okay,
Okay.
on my turn. Okay. Thank you very much.
I think it's my software's problem. I cannot upload my PowerPoint. I try again. So really sorry.
In your country, Zoom
In
is
your
allowed,
country,
right?
Zoom is allowed.
Yeah, Zoom is not allowed, but I through the VPN I can get connected with the outside. But I don't know how. Why it's a problem?
Via WhatsApp
Or
video
via
call so that I
WhatsApp
can
video
guide.
call so that I can guide.
I just cannot.
Okay.
Okay.
Okay, now it's
Okay,
you
now
can
it's
speak.
you can speak.
It's okay.
Yeah.
Yeah.
So could you see
Yes.
my
Yes.
slide?
Yes. Yes. Please
Yes. Yes.
continue.
Please continue.
Okay. Thank you very much, and I'm sorry to waste the time, and really sorry. And my it's very happy to say hello to everyone, and happy to share my my topic. It's cervical kyphosis, based on the fundamental knowledge and my clinical experience. The development cervical kyphosis is a complex condition driven by a variety of underlying causes, especially degenerative changes, congenital anonymous traumatic injury, infective process, and iatrogenic factors all contribute to this spinal deformity. And among all the underlying etiology, iatrogenic postoperative factor remain the most common cause. Postoperative cervical kyphosis are frequently associated with prior posterior decompression surgery, such as laminectomy or laminoplasty. This iatrogenic loss of sagittal alignment shift the weight-bearing axis anteriorly, placing excessive stress on the spine. Ultimately, this mechanical deterioration leads to severe function limitation and significantly diminishes the patient's overall health-related quality of life. The development of cervical kyphosis is primarily driven by the severe compromise of posterior spinal column stabilizing structures, especially the atrophy of posterior cervical muscle. Significantly weakens the dynamic support required for long-term stability. For more, the structural disruption of facet joints and the ruptured posterior tension bands crucially impaired spinal mechanical integrity. So together, this factor result in profound loss of sagittal balance, ultimately culminating in severe cervical kyphosis. The comprehensive evaluation patient with cervical kyphosis rely on the precise radiographic assessment. It's essential to analyze the cervical alignments alongside spinal pelvic parameters, as their correlation detects global balance. Understanding this relationship is crucial for accurate diagnosis and effective cervical planning. This graph shows the average value of normal cervical parameters. We should know that CO1 cup angle is the only positive value parameters among cervical parameters, and C12 cup angle takes up the major cup angle of the cervical cup angle.
C27 sagittal vertical axis is offset from C2 pump line to the posterior superior corner of C7. Normal values are about 1.5 centimeter, which is a significant correlating with the health-related quality of life. Also, the CBVA is another important parameter significantly correlating with health-related quality of life, as the loss of the horizontal gaze had a significant impact on activity of daily living of quality of life. Cervical thoracic junction parameters including thoracic inlet angle, T1 slope, and the neck tilt, which not only reflect cervical thoracic junction alignment, but the harmony of this junction region with cervical region. A small T1 slope always matches a small cervical lordosis, and vice versa. We also need to know the cervical alignment with mutually interactive with thoracic and lumbar alignments. These different types of cervical kyphosis influence the global alignments with different ways. The flat neck deformity needs to maintain a balanced head, having a C7 pump line posterior shifting from the pelvis with a large lumbar lordosis, small PI lumbar lordosis match, small T1 slope, and thoracic hypokyphosis. But the cervical thoracic deformity needs to maintain a balanced trunk, having C7 pump line on the pelvis with a small normal or small lumbar lordosis, a small PI lumbar lordosis match, large T1 slope, and thoracic hyperkyphosis. The more important we need to know is that progressive cervical kyphosis could gradually result in a gliosis of anterior column cervical cord and impose the cervical cord on a longitudinal tension, which contribute to the development of myelopathy. Classification is important and help us to guide the clinical treatment. Earlier classification were based on the etiology of deformities, not radiographic characteristics of treatment. AIMS classifications for cervical spinal deformity was broken down into 5 descriptors with 5 moderators to account for sagittal vertical axis, horizontal gaze, vertical lordosis, myelopathy, and the overall SIS swap classification. The AIMS classification provides a uniform nomenclature system for deformity surgeon to use when discussing patients. However, this classification was not based on the health-related quality of life and the classification does not guide treatment. Then AIMS proposed his classification of cervical osteotomy. Building upon the unified language provided by the AIMS classification, Kohler established treatment guiding algorithm for patients with rigid cervical kyphosis. Deformity type A corresponded to a patient with cervical thoracic kyphosis with maintained global alignment. Type B corresponded to cervical thoracic kyphotic deformity with concomitant global imbalance. Type C corresponded to a cervical thoracic kyphotic deformity with inadequate compensatory cervical lumbar and the persistent global imbalance. Type D corresponded to patient with appropriate cervical lordosis and maintained global alignment. A patient with type A deformity were more likely to require a combined anterior-posterior surgical approach, while patients with type C deformity were more likely to undergo posterior approach with high-grade osteotomy for adequate deformity correction. However, like Ames classification, the Kohler classification solely used static radiographs. Moreover, the Kohler classification simply reports the most common the techniques used by their cohort surgery with limited discussion on the biomechanical reason of this strategy. So given the Ames and the Kohler's classification realigns on the static radiographs and limited ability to guide the surgical correction, the Kin and the SISSG in 2020 published a new classification schema. The Kin classification schema utilized a dynamic cervical spine image to create a treatment guide classification schema for cervical kyphosis. Classification using the Kin schema requires full-length standing anterior, posterior, and the lateral spinal radiographs and dictated AP, lateral flexion, and extension cervical spine radiographs. The Kin classification identified 4 distinct classes of cervical spinal deformity. Number 1 is flat neck deformity. Number 2 is focal kyphotic deformity. Number 3 is cervical thoracic deformity. And number 4 is coronal deformity. The recent Sandamiller classification was published in 2026. That is this year. The radiographic parameter used to classify the groups are based on the cervical alignment parameters such as cervical SVA, T1 slope, and T1 slope plus a cervical sagittal angle. A total of 4 types were classified in this system to identify the primary driver of the deformity, leading to a higher cervical SVA, but the classification system is yet to be validated. Generally, the making of cervical kyphosis as a surgical strategy is based on the flexibility of cervical spine. If the cervical spine is flexible, the cervical kyphosis could be corrected by ACDF, ACCF, PSF, or AP combined approach. If the cervical spine is fixed but not ankylosed, anterior release and reconstruction are needed. If the cervical spine is enclosed, anterior or posterior osteotomy or combined approach are needed. So let's take a look at some cases. This is a mild kyphosis. He come to my clinic because of myelopathy. The cervical spine is flexible, so I did 3-level ACDF to achieve a perfect reconstruction. Compared with a preoperative radiograph, all cervical parameters were improved significantly. This patient have a delayed C5-6 dislocation. He complained consistent neck pain. His cervical spine is fixed because the deformity is a focal issue. So I plan to do a ACDF, but found the C5-6 process gap was wide after C5-6 ACDF. So I realized posterior band was failed. So I supplement C5-6 pedicle fixation to reconstruct the cervical spine. We can see that the global spine was realigned very well after cervical surgery. This case is very interesting. The cervical is fixed and ankylosed at C5 to 7. I initially planned to do an AP combined approach, When I finish the anterior release, it seemed that cervical lordosis could be restored through the multi-level ACDF and ACCF. So I quit the posterior approach surgery. After surgery, his long-term neck pain disappeared, and the posterior X-ray showed all spinal parameters was significantly improved. This is a failed ACCF case. The patient came to my clinic due to neck pain and myelopathy. I took out the mesh cage and block and reconstructed the cervical again with an AP combined approach. And we can see the reconstruction is perfect. And this is a typical neurofibromatosis deformity. I did the APA approach with a 4-level ACDF and the PSF to reconstruct its cervical lordosis. So the follow-up CT scan showed there was a solid fusion achieved. From the flexed and extend picture showing, the range of motion of the neck looks pretty good. This is a dystonia flat neck case. This patient lost her horizontal gaze. I did the AP combined correction surgery to recover his horizontal gaze. After surgery, she regained his horizontal gaze and the global spine realigned very well. This is a Parkinson kyphosis after the laminectomy. This patient felt consistent neck pain. I did T1 PSO to pull back his neck. You can see when his neck was pulled back, his malaligned global spine was improved significant. The CSVA after surgery was improved, obviously compared with preoperatively. This is a post-kyphosis case. The 3D CT showed the deformity was fixed, and MRI showed the syringomyelia distal to the apex. The surgery is a challenge because I cannot resect apex C6 from the front unless I split the manubrame or resect the C5 together. So another obstacle is the fused lamina that prevent to open the cervical spine. So I did C6. I did a C6 7 PSO from back. A CT scan after surgery showed the cervical spine realigned perfect, and the X-ray showed the global spine alignment improved very well. The last demo case is infection kyphosis after ACCF. The instrument was dislodged totally. MRI showed the spinal cord was impressed. Obviously, I did anterior debridement and reconstruction with posterior spinal fusion as well to achieve a normal cervical alignment. After surgery, his neck pain and the symptom of myelopathy was relieved, obviously. So in summary, cervical deformity can significantly hinder the patient's quality of life. The variety and the relative paucity of the data has resulted in heterogeneous management of a patient with cervical deformity. Ultrasonic remains the most common cause. Preserving the muscles and posterior tension band is crucial. A radiographic assessment and the classification could instruct clinical doctors treating cervical deformity. Anterior posterior APA combined approaches and osteotomies are options. to treat cervical deformity according to different kyphosis and cervical flexibility. Thank you very much.
Thank you very much, Doctor.
Thank you very much, Doctor.
Congratulations.
Congratulations.
Excellent presentation.
Excellent presentation.
Amazing.
Amazing.
Thank you. Thank you for sharing your
Thank you for
knowledge
sharing
and your
your
experience.
knowledge and your experience.
Is there any question?
Mutlu olasın.
Ferda, bunu tabii. Una padrissima.
Me posso aiutare?
Evvelden galiba.
Yeah, hello. Dr. Edson, now it's your turn, right?
Yes. Yes, I'm here. Are you hear my screen? Are you see my
Yes, we
screen?
can see. We can see. We can see.
Dear friends and colleagues, I'm so happy to be here and to be a part of this webinar. Today I will speak about surgery of basilar artery aneurysms. My first picture is the picture of Professor Einstein. Why I put this in my presentation? Because we are on endovascular era, and we have this thesis that posterior circulation aneurysms should be treated endovascularly. I don't have anything against endovascular therapy, but and the role of endovascular therapy increase every year, but for posterior circulation, it's just a thesis that they should be treated endovascularly. Posterior circulation aneurysms is about 20% of all aneurysms, and they have higher rupture risk in compare with anterior circulation. For orienting in these operations, when we read about basilar apex aneurysms, we see a lot of craniotomies and approaches. It's subtemporal, pterional, lateral, supraorbital, OZ, cisternal, transsylvian, transcavernous. And for orienting in these approaches, we should know the history and the philosophy of these operations. Charles Drake in 1964 present his results via subtemporal approach, and only 20 years later, Professor Yashargil, he present his 50 cases series, and his first 9 cases operated via subtemporal approach, and he he could clip only 4 cases. And he noticed the disadvantages of subtemporal approach. Subtemporal is a very similar approach, very simple approach, and give us a quick access to the pathology. But disadvantage is we always need very slack brain, very lax brain, and very poor contralateral P1. Professor Yashargil demonstrates his Transilvan approach. And you see in his book, the dividing of tentorium and also the dividing of PCOM, firstly he described. This anatomy is famous triangles, is opticocarotid triangle, supracarotid and oculomotor triangle. Mostly we use for clip ligation oculomotor triangle, and this is the only triangle which can we increase in size. But for operations, we use all these triangles because, especially for large aneurysms, we can put clip from oculomotor triangle and control the blades from optic carotid triangle. Supracarotid triangle mostly obstruct by perforators, but we use it for high riding basilar aneurysms. Cisternal approach, the pretemporal cisternal exposure, we need wide Sylvian fissure exposure. We occlude at the level of sphenoparietal sinus Sylvian vein, and sometimes coagulate and cut anterotemporal artery. And with these maneuvers, we mobilize temporal lobe, and we can retract laterally and posteriorly the temporal lobe and increase oculomotor triangle, like in this slide. I said about it, the dividing PCOM. PCOM have perforating free zone, and if don't exist fetal tip PCOM, we can easily coagulate and cut, and this gives you some advantage. It increases working area, frees PCA, removes obstruction of PCOM itself. The other crucial moment is the thalamus perforators. Mike Lawton said about them, the vessel of Tess. Some variations is percheron artery when unilateral trunk and gives to the so many branches. Another picture from Professor Yashargil's book. We have 3 anatomic variants: anterior projection, superior projection, and posterior projection. Actually, anterior projection is the simplest one because perforators are behind the neck. Superior one, we don't see perforators, and the posterior one is the most difficult. The surgical corridor obstruct was candelabra of perforators. And also we have high riding and low riding aneurysms. For low riding, we need posterior clinoidectomy, and for high riding, usually we need OZ approach. Clipology for superior and anterior projection aneurysms, we need just simple clipping. For posterior projection, mostly we use fenestration clips for fenestrating P1. Some cases from my this patient has 3 aneurysms: left MCA, ACOM, and basilar tip aneurysms. Operated via cisternal OZ approach, and all 3 aneurysms were clipped. Another patient, also 2 aneurysms, large unruptured MCA and ruptured basilar tip. Also, we operated via cisternal approach. I show you intraoperative video. You see basilar trunk, P1. Opposite P1. Now, basilar trunk. And aneurysm was nicely occluded. Second. Another patient with ruptured case, superior projection, aneurysm dome slightly tilted posterior, but it's superior projection. You see wall anatomy and aneurysm nicely occluded. And transcavernous approach, my favorite approach, because in this approach we have some advantages. We don't depend on anatomy, rather high riding or low riding. We can expose everything. We can even do anterior petrosectomy and operate basilar trunk aneurysms. This picture from Professor Krisht presentation, you see oculomotor membrane is cut and third nerve is mobilized, and this gives you the very panoramic view. And for transcavernous approach, it's very easy for surgeon because all anatomy becomes more superficial in compare with cisternal approach. This is full cavernous exposure. Of course, we don't need full cavernous exposure for all cases. In most cases, we just need to open oculomotor membrane, and sometimes mobilize fourth nerve. Uh, this aneurysm operate via transcavernous approach. This one. Mhm. Sorry for interruption. See, we see anatomy more superficial and compare with cisternal approach. We nicely see basilar, all P1s, columnar perforators. And aneurysm, which nicely occluded. Also circular well. And last case, this SCA ruptured case. See a large SCA aneurysm. SCA more simple than basilar tip aneurysm because SCA not associated with perforators. Good. And you see how superficial to the surgeon's view, just like MCA aneurysm. For basilar, very crucial is proximal control. Only for small unruptured aneurysms you can put the clip without proximal control. Otherwise, it should lead to the disaster. Okay. This is my last case. Previously coiled aneurysm, giant thrombotic and posterior projection. I can occlude aneurysm, but I can't remove clots and coils, and patient tolerate procedure well, and we put VP shunt after surgery. Transcavernous approach, you see oculomotor nerve was nicely freed. And some statistic, you know, these famous trials, barrel ruptured aneurysm trial. What's interesting in barrel trial, that's the crossover from coiling group to the clipping group. But for clipping group, 98% of patients assigned to clipping had clipping, but only 62% of 199 patients assigned for coiling had coiling. And clipping had excellent occlusion rate. We see 6-year follow-up. Complete aneurysm closure in 96% of clipped group and only 48 for coiled group. But coiled group for posterior circulation aneurysms, coiling outcomes were superior to coiling, to clipping. ISAT, ISAT said that the coiling is superior to clipping, especially for posterior circulation aneurysms. But also, ISAT said that for young patients, clippings have some advantages. I really love this Washington trio, Lalikam Saker's group. In 10 years, they operated 100 aneurysms. You see how they select the patients. Broad, large neck, branched arising from the neck, and large aneurysms, and young patients were assigned for open surgery. So 67% endovascular, 33% microsurgical. And there is no significant difference in outcomes in both groups. But occlusion rate and retreatment rate is much more better for microsurgical clipping. And you see retreatment rate is 17%. And 27% of them have more than one retreatment. And what's interesting, this slide, recurrence rate for ruptured and unruptured cases. You see for ruptured is much more worse. For coils and clipping. And what's interesting is the recurrent progression for basilar. Near 40% of basilar have recurrence in 10 months. And you see how low is for MCA, because MCA mostly operated by microsurgical clipping. The other study from World Neurosurgical, this paper in World Neurosurgery Journal, you see microsurgical technique remains the most treatment modality with the complete occlusion and the lowest rates of rehemorrhage and retreatment rate, but most morbid. It's our result is 12 patients operated in our hospital. And some conclusions. Most consider endovascular therapy for the first choice. There is a role for microsurgical clipping, young patients, wide necks, coil recurrence, thrombotic, giants, fusiforms, and SCA aneurysms. And I end my presentation with the words of great Professor de Oliveira. Venous surgery is a superior option when done at superior level. Thank you for having me. Great pleasure for me. See you. Any comments, dear colleagues? Şeyde bağlı, telefonda.
Do you hear me? Please let me know when I can proceed with the next presentation.
Yes, Doctor, I'm attending. You can start anytime.
Thank you. Okay, can you see my slides? Can you please confirm that you can see my slides? Does anybody hear me? Can you hear me, please? Can you see my presentation?
Yes.
Thank you very much. So, we're gonna talk about the occipito-cervical fixation and the posterior C1, C2 fixation. I would like to thank the organizing committee for the invitation, and I'm really happy to be with you today. I do not have any conflict of interest. So we're gonna talk about the C0, C1, C2 fixation and the C1, C2 fixation. A few words about the anatomy, the indications and the planning, as well as the surgical technique and the complications. Starting from the anatomy, we should not forget that there are some landmarks that you already know, but it's always better to make a small reminder. Um, Starting from superficial to deeper layers, you have the external occipital protuberance with the superior nuchal line. And we will find in our approach some muscles. We will find the trapezius over here and the splenus capitis even deeper. We see here the splenus capitis and the semispinalis capitis muscle with the greater occipital nerve here. In this image, we can see better the semispinalis capitis muscle, and in even deeper layer, we will find the rectus capitis posterior minor and the rectus capitis posterior major, two muscles that are located in the C0, C1 region in a triangular shape, and they give access to the craniocervical junction. In another photo, once we have displaced these muscles, we will see the occiput with the foramen magnum, the dura, the posterior arch of the C1, and also, of course, we will find the vertebral artery with the posterior meningeal artery. Here in another specimen, we can see the C0, C1 junction with the posterior arch of the C1, the posterior tubercle. We can see in both sides the vertebral arteries in the groove. And in the C1, C2 region, we will find the paravertebral venous plexus, where just beneath we will find the C2 nerve root. Again, some osseous landmarks: the external occipital protuberance, the superior nuchal line, the external occipital crest, and the inferior nuchal line, the foramen magnum, and the occipital condyle. A few words. This is a photo of an anatomical specimen of C1 in a superior and posterior view. We can see the lateral masses of C1 with the foramen transversarium, the anterior arch with the anterior tubercle, and the posterior arch with the posterior tubercle, as well as the groove for the vertebral artery. And just below, we will find the C2 vertebra with the most characteristic feature, the odontoid process. Of course, this region is really important because we will find many ligaments. Maybe the most important and the most memorable one is the transverse band and the cruciate ligament. But there are also some particularities like the apical ligament that we see here and the alar ligament in both sides. And of course, we will find the rest of the ligaments that we usually find in the spinal column. Apart from the muscles, the osseous landmarks, we have also a risk for vascular injury. So you should remember that just below the external occipital protuberance and the superior nuchal line, we have also the transverse sinus, and in the midline we will find the occipital sinus. And in this schematic illustration, which is a bit simplified, we find the trajectory of the vertebral artery. So when do we perform an occipitocervical fixation? We do it when there is an atlanto-occipital instability due to trauma, malformation, inflammatory rheumatism, or tumor. When there is an atlantoaxial instability, when we have an unstable C1 fracture, or even in some cases of occipital condyle fractures, but most of them we treat them in a conservative manner. In terms of contraindications, some authors describe severe osteoporosis as a relative contraindication. And of course, the absence of a large part of the occiput is a problem because we cannot perform the fixation in the occiput. And this arrives in cases of previous surgeries with posterior fossa decompression. Before the surgery, it is important to have an angioscan, to have a CT scan with bone window, with really good quality, plus an angioscan in order to study the osseous 3D anatomy, see the level of the transverse sinus and the trajectory of the vertebral arteries, because in some cases, like this one, we can have some variations, like a persistent segmental artery, rendering the positioning of the C1 pedicle screw really risky. So, how do we do it? We install the patient in a prone position with a Mayfield. It should be strictly neutral position without flexion or extension. And we perform a posterior midline incision. So once we have exposed our landmarks and our osseous landmarks, we will start from positioning the C1 screw. Okay, so here in this photo, we can see from the superior view that the trajectory of the screw is slightly inwards. And in the posterior view, we can find that the entry point is just beneath the posterior arch of the C1 in the midline of the facets. We will come back later into this. And from an inferolateral view, we can see that the trajectory in the sagittal perspective is slightly ascending. So again, the entry point in the midline of the facets, just beneath the posterior arch of the C1, we will put our entry point. Here we can see it in the 3D scan reconstruction. And in this schematic illustration, we see again the positioning of the entry point for the C1 screw placement. And we should mention that at this point we have we have dissected the paravertebral venous plexus, we have controlled the bleeding, and we have displaced the C2 nerve root inferiorly. So, again, into this schematic illustration, we can see the paravertebral venous plexus. Some surgeons prefer to cut the C2 nerve root. We don't actually do it. We prefer to preserve it. So we put our entry point, okay? We perform some drilling, tapping, and we use the spatula, okay, as we can see here, in order to control the medial border of our trajectory in order to not have an osseous contact that passes the cortical bone. So the spatula actually at this point acts as a way of protection in order to not have a very convergent trajectory. So as you can see, the direction it's more or less 10 to 20 degrees inwards and upwards. Okay. For the C2 screw placement, there are many ways to do the fixation, many ways described in the literature. However, I will speak about the two best into brackets. The best one that we use it in first intention is the pedicle screw, where we see it here in light blue color. And the other one is the laminar screw in orange color. For the C2 screw entry point, again, according to the Harms technique, we use the midline of the facets, okay? But in this case, we put the entry point slightly superlaterally in order to give better convergence. In a similar way, we perform some drilling, tapping. We use the spatula to control the medial border. But in this case, you can see that the trajectory is more convergent, okay, and slightly upwards, like the C1 screw placement. Of course, there are other techniques described that are really used still in our days by many colleagues, like the McGirl technique, which is actually an intra-articular, transarticular C1 C2 fixation, but the trajectory is way more ascending. And of course, we have the laminar screw placement, which is a really good alternative, and we use it a lot when the pedicle screw placement is not possible. This is a good example of a C1, C2 fixation with bone graft. Okay, and here you can see the screw placement in this schematic illustration according to the Harms technique. So once we have put the C1, C2 screws, we will place the C0 screws in the occiput. Our area of interest is over here, just below the superior nuchal line, and in a paramedian fashion to the occipital crest. We will put the plates with the rods, okay, and we will perform some drilling, some tapping, and we will insert our screws. We will put at least 2 per plate, 4 in total, and ideally it should be 6 screws for a better grip. It is important to measure the length of the screws and add a bit of like 1 or 2 millimeters more in order to have a bicortical screw placement and have a really strong grip. This is an example where we can see perioperatively the bone graft. You should not forget about the bone graft, which is really important for better fusion outcomes. And this is an example, a preoperative image where we performed the C0, C2 placement. We didn't choose for this one to put a C1 because we had a really good grip in C2. So some tips and tricks. You should always evaluate the indication. Why do we perform the surgery? Should we do it, and why? We should evaluate the patient posture and the bone quality. The patient should be informed about the reduced mobility in terms of flexion extension in C1, C0, and especially rotation in C1, C2. Again, the anatomy is very important. We should study the 3D anatomy before surgery, use the landmarks, and of course, navigation is very, very recommended if feasible. You should be prepared for a bleeding, especially from the venous plexus in the C1, C2. But of course, there is a risk for a serious vascular injury like the vertebral artery, which is feasible, but you should always pay attention. You should not stop at C1 when an atlatoccipital fixation is indicated, and you should always try to put at first intention C2 pedicle screws. At least this is our experience. So if anatomy is favorable, prefer to use C2 pedicle screws, and if possible, bicortical screws for a better grip. If not, C2 laminar screws can be really useful and have acceptable results in terms of biomechanics. When the C0, C1, C2 fixation is satisfactory, there is no need to extend lower to C3 or C4. And it's better to always use bone graft for better fusion. In terms of complications, you should pay attention to dysphagia, especially when there is an excessive flexion. Some postural problems, of course, infections, CSF leaks, surgical site hematoma are in the complications. And apart from the vascular lesions, we have material-related complications like screw displacement or fracture. These are my references, and thank you for your attention. I don't know if there are any comments, any questions.
Yeah, I have some question. Thank you
Yes.
for nice presentation, very good results. And sometimes when you put C1 screws, you have a huge bleeding from epidural and paravertebral veins. How you can deal with it?
Actually, it's almost in every case. It depends. You can use some like flow seal or Flow that works really well. Give some time, wait some minutes in order to control it, and it stops. Apart from certain cases where you have a continuous bleeding, where you don't have any other choice but to continue and put the screws. But give a few minutes. I always use some flow seal, some Surgicel, and it stops.
Okay. And thank you. And did you have cases when you damage the vertebral artery on this level, and what you can do in such cases?
Again, it is the preparative planning that it's really important. It's always better to use navigation, but it's not. I mean, it's not 100% security, of course. We had some cases that, but it's really rare. It's really rare because you have to feel with the palpator. You have to feel always the trajectory and reassure that you have osseous resistance in the walls of the trajectory. But if you have a vertebral injury, it depends on the dominance of the vertebral artery, and of course the clinical evolution of the patient. But it's relatively rare in our experience.
Okay, thank you. And if you have already diagnosed intraoperatively or postoperatively that you have damage in vertebral artery, would you send the patient to a radiologist to coil it?
Yes, it's an option. It's an option. We will try to. It depends on the compression, but of course there is the question of the reoperation. But in any case, at this point, you should inform before the neuroradiologist in order to be ready.
Okay, thank you so much.
I also have a question. May I ask you also a question? First of all, thank you very much, Dr. Gregorius, for your outstanding presentation. In case if ligaments are intact, have you experience of removing these screws after some time? And if yes, what is your strategy?
No, generally speaking, you shouldn't remove it.
Okay, got it. I appreciate it. I have the same idea, but I have have listened to some lectures where some people remove it, and I wanted just your opinion. Thank
I
you.
don't
Appreciate
think it's a good idea. I don't think, especially if you have used bone graft, it's way too aggressive. There's no real interest.
it. Okay, got it. Appreciate it.
Hello? Who is next? I think Dr. Gutenberg Jean is next.
Yes, I'm here.
Yeah. Could you continue your presentation? Dr. Gutenberg, could you continue your presentation?
Yes, give me 5 minutes, please. I will share my presentation as well.
Maybe you want me to start, and
Okay, Dr. Edisha, you can start.
Yeah, you can start. You can start without problem. I will.
do you see? Share. Do you see my screen?
Yes, I see it.
Okay, then I will start. My talk is about endoscopic transorbital surgery through superior eyelid approach. I'm doing this work for the last 5 years. And if anyone will have some questions during presentation, they can interrupt me and ask questions. So I have nothing to declare about this topic. The exploration of transorbital surgical corridor began almost 150 years ago, but during the last decade, because our new instruments, endoscope, magnification, illumination, some instrumentation, there is an update, and it became much more interesting, this corridor for neurosurgeons. The rigid description is that to get in the school, inside the intracranial space through the intraorbital space without orbital rim removal. But now at the moment, we often use orbital rim removal or orbitotomy. And we call it extended approach. So BNI in 2021 published the literature review of this topic, and in this article, they have reviewed the history of it. Everything started with Hermann Knapp, who described anterior orbitotomy. Then there was a great Swiss surgeon, Rudolf Kronlein, who did lateral orbitotomy and then was Charles Fraser, who did superior orbitotomy. And now, even for anterior communicating arteries, I use this very often in pterional approaches. Here, then there was Gerard Guyot, who did first neurosurgical skull-base endoscopy, then removal of the orbital foreign body with endoscope of John Norris and Gilbert Clisby. And then there was Chris Moore, who first published and introduced to the public tones, conception on tones. We call it transorbital neuroendoscopic surgery. He published 20 operations on 16 patients. After this, we were pretty much interested about it, and the team of Alberto Soma and Pablo Capabianca, they have published endoscopic transorbital superior eyelid approach from neurosurgical perspective. And here you can see they have done superior eyelid skin incision, entered the intracranial space, made the bone removal, and made the volumetric analysis. Where do we get inside the skull from this approach? And here you can see it is very actual place, because it is very actual place because it's pterional approach, and it is workhorse of neurosurgery pterional approach. They have described 4 major approaches, like lateral corridor to the middle cranial fossa, lateral corridor to the anterior cranial fossa, combined approach to anterior and middle cranial fossa. And I want you to see this picture. This is optic canal, this is superior orbital fissure, and optic strut is just in between them. And we can even do anterior clinoidectomy from this approach, and I will show some clinical and intraoperative examples of it. So there is also medial corridor to the opticocarotid region. So also they have Matteo De Notaris and Jacopo Dylan. They described in 2017 endoscopic transorbital road to cavernous sinus through meningoorbital band. This is the same approach. We neurosurgeon, we call it Hakuba Dolenz approach, but done through superior eyelid approach. We can see meningoorbital band can be splitted, and we can enter cavernous sinus, and you can see here cavernous sinus structures, 3rd, 4th, and 5th nerve, and all these 3 branches of it. And I will also show you transcavernous approach to the petroclival region. So Du-Si Kong and Chang Ki Hong from Samsung Hospital, Korea, they have published trigeminal schwannoma cases, 50 cases operated through superior eyelid approach, and here you can see how nicely they have removed trigeminal schwannoma from this tiny approach. And they found this very pretty much useful and effective in all the types of trigeminal schwannoma except type B, when the tumor is located majorly in posterior fossa. So we have 2 major approaches. If we are going in the anterior cranial fossa, middle cranial fossa, or temporal fossa, we use Sanderect approach without orbital rim removal, and we remove orbital rim if we want more media, we want to make anterior clinoid region, Petros apex, middle cranial fossa floor, GSPN exploration on cutting meningoorbital band. In this case, we use the extended approach on the frontozygomatic suture. Now here are my case series, which we have done at Tbilisi in American Hospital. Here you can see meningioma. It's anterior clinoid meningioma. we decided to go transorbitally, and here is intraoperative view. It is right eye. We start with, it was not extended approach. We start orbital rim fluttering. It's very important to gain space and minimize the eyeball and intraorbital tissue retraction. Then we drill bone until we get to temporal fossa, and medial fascia of the temporal muscle is seen. After it, we continue drilling greater sphenoid wing until we see the dura of the temporal pole, until we open the middle cranial fossa. Then we enlarge craniotomy. After craniotomy enlarging, I have cut the dura, sutured the medial part of the dura to get more comfortable. And here you can see this is a Sylvian fissure, frontal basis, medial temporal side. And here you can see tumor, which we start removing step by step. After tumor removal, we have coagulated the matrix of the tumor to get Simpson 2. During the surgery, we monitor eye, and I pretty much love this video, how we can get through this approach to middle cranial fossa with endoscope directly. After complete tumor removal, we're just making hemostasis, putting some fat graft, and Barcelona University have published volumetric analysis about this fat graft, that during 3 months after surgery, it reduces its volume from 70 to 80%. So here is postoperative MRI scan of the patient. The tumor has been completely removed. Here is our bone resection. This is the place where we have opened the temporal fossa. And here you can see the nice cosmetic result of small craniotomy. And here you can see this is the skin incision. We did not make pterional approach. We have not done Sylvian fissure splitting, no retraction or much less brain retraction. And here is the patient on the left side. It is 1 month after surgery. And here we can see when she was looking left, she had a little bit diplopia, which completely gone away within 2 months. Our next case is lateral sphenoid wing meningioma or orbital roof meningioma, when we have used the lateral corridor to the middle cranial, to the anterior cranial fossa. Here we have also had complete tumor removal. Our next is a temporal pole carcinoma. The patient was brought to my department with first onset epileptic seizures. We decided to do surgery, but everything is the same, but the eye is left here in this. So we make periorbital dissection, drilling and fluttering orbital rim just a little bit, a couple of millimeters is more than enough. Then we're opening the temporal fossa. Here you can see the temporal pole, dura, enlarging craniotomy, removing the sagittal crest, opening the dura, and we just see this carcinoma just in front of us, without pterional craniotomy, without Sylvian fissure splitting, without any bone retraction. We have made some quite aggressive circumference resection of the lesion. We made it aggressive because it was epileptic case, and we wanted to remove just a little bit more brain tissue, which was already affected and which was cause of epileptic seizures in this patient. Lesion has been removed, standard hemostasis, and closing the wound. We have done 18 millimeters bone resection, 18 millimeters bone resection in this case. Lateral corridor to the middle cranial fossa was used. The lesion has been completely removed. And here is our patient 10 days after surgery. You can see the skin incision here, which is a couple of centimeters here, and the patient 1 month after surgery with excellent cosmetic result. We have published this case in Operative Neurosurgery. We have some citations about this article. One more case. This is optic nerve 360-degree decompression because of fibrous dysplasia, which was causing the kid was previously operated about astrocytoma of posterior fossa, and then here you can see the medial and lateral side of the optic canals are affected. It is narrowed. There is a huge compression of optic nerve. The kid was getting worse every month about his vision. We observed this case for a couple of years. The kid was previously in another country, in another institution, operated twice, once from the nose, another time from terminal approach, but they did not succeed to remove this lesion. I don't know why, but then he was referred to my hospital, and we did 360-degree decompression. We started from transnasal approach. You can see here, this is optic nerve, this is orbital apex, and the medial part of the lesion has been removed. But anterior clinoid was also affected in this case, and we wanted to remove the lesion completely because it was growing after our dynamic when we were doing some MRI scans and CT scans in time, we have seen that it has been growing, and we decided to make anterior clinoidectomy also from superior eyelid approach. And here you can see this is eyelid, this is eyelid, this is eyebrow. Here is a skin incision, the same couple of centimeters skin incision. But in this case, because we wanted to make anterior clinoidectomy, we did orbital rim removing. So we cut it and removed. After this, we start drilling the greater sphenoid wing. We do monitor the eye and eye pupil during the surgery. We retract intraorbital tissue with retractor, with standard Mayfield retractor, not Mayfield, with standard Leila retractor. I use Cobra from how the company is called. The company made Blackforth Medical, the company who produced, but it doesn't make sense. It's like Leila type retractor. We start drilling the greater sphenoid wing. After drilling the greater sphenoid wing, you can see here is affected anterior clinoid. Just below it, you can see meningoorbital band, which was cut a little bit, and we drilled anterior clinoid. After it, anterior clinoid has been mobilized, and here you can see this is optic nerve inside its shield. After quite aggressive anterior clinoid dissection, because it was in a very tiny relationship with the surrounding dura mater, we have removed it. And after anterior clinoid removal, you can see here this is optic nerve. This is ICA, but it is, yes, it's just after cavernous sinus, supracavernous part of the ICA, and we continue drilling to remove all the affected bone. And here you can see the complete removal of anterior clinoidectomy and 360-degree optic nerve decompression. Every bone has been removed which was affected, and here you can see our quite good result. Immediately after surgery, the kid has ptosis, which reduced within 3 weeks. 3 weeks, and also he had a worsening of the vision on this eye, but he really 2 months passed after surgery, and he really improves very, very fast. This is my last case I want to introduce. This is the patient. First, I thought it was a trigeminal schwannoma, but in reality, it turned out to be petroclival meningioma and meningioma of the Meckel's cave. We decided to go through meningorbital band to go transorbital transcavernous approach to this lesion. Here is an intraoperative video. It's the hope. Oops, I will remove it. This is our operating room setup. This is schematic illustration generated by IE. The surgeon stands on the affected side, the assistant on the contralateral side. I use open door extended approach. Spatula retracts the orbital tissue. And here you can see how I leave the orbital rim on the temporal muscle. We start periorbital dissecting, then drilling until usually majorly the greater sphenoid wing until we will reach the middle cranial fossa. Then we enlarge craniotomy, cutting meningorbital band and dissecting cavernous sinus. During cavernous sinus dissection, we can see all the cavernous sinus structures like third, fourth nerve, fifth nerve. This is fifth nerve and all 3 branches of it, V1, V2, V3. After cavernous sinus dissection, we reached Parkinson infratrochlear triangle, and tumor was removed to infratrochlear triangle. After removing the part of the tumor from the Meckel's cave, we can see here the dural enlargement of dural defect through which tumor was going to posterior fossa. We have removed this part of the tumor also, and after complete tumor removal, you can see the arachnoid layer of here. You can see the arachnoid layer of posterior fossa and the brainstem, and this is the root of trigeminal nerve. And here you can see the bone erosion and bone fragments that were destroyed by the tumor within its roots. These bone fragments were also removed. And this is the root of trigeminal nerve. We have made hemostasis. And this is Parkinson's triangle. Here you can see this is the fourth nerve and this is the fifth nerve. Making some standard hemostasis. Here is some minimal dural defect, which was hermetized by Tahoe seal. Put some fat inside, and we have done complete lesion removal. Here you can see it has been totally removed. And this is the patient with its skin incision 2 months after surgery. This is our bone resection. Just an orbital rim has been removed a little bit, and backside of the orbit. Here is our surgical trajectory on the CT scan. One more time, complete tumor resection. You can see which was confirmed with MRI scan. Patient 2 months after surgery. How to close this this wound. We have published in Acta Neurochirurgica the 4F fat fascia fibrin and fat technique to close the wound. And I usually present these cases everywhere in Europe, in United States. We are doing some dissection courses. The last one was in China, and our next one will be in Barcelona, and we do it all over the world, including United States. And I am part of ETHOS. It is called Endoscopic Transorbital Society, to teach our next generation. Thank you very much for your attention. If anyone has any questions, I am feel free.
Thank you so much. Excellent presentation.
Thank you so much, doctor.
Intraoperative cases. I have one question. As a spinal endoscopic surgeon, sometimes when we perform endoscopic operation and have some dura damage or some complication, we have to switch to microsurgical operation. Do you have such cases when you have to do it?
No, because there is a tremendous difference between this endoscopy. Even if we do transsphenoidal surgery and we have some CSF leak, we do it endoscopically. We don't need microsurgery. But here, in comparison with transsphenoidal surgery and even spinal surgery, the risk of CSF leak is much, much more lower because CSF cisterns pressure is lower in this case. So we have something about 0.01% of CSF leaking. And we had, because this ethos, this transorbital society, we are from a lot of countries and we gather all information. And about CSF leak, we have analyzed all the patients from all over the world, not only my cases. About 350 cases we have analyzed. And CSF leak was below 0.01%. And in all cases, it reduced with just lumbar drain. Only in one case, there was revision of the wound, and it was done endoscopically.
Okay.
But we need more cases. When we will have more cases, we will have more complications and more problems.
Yeah, amazing, amazing. Thank you.
I appreciate it for your attention.
Yeah.
Thank you so much, doctor. So could I request Dr. Sarif to continue his presentation? Hello, Dr. Gertenberg. Are you available to present now?
Yeah, I'm ready. Hello, I'm trying to share the screen.
Okay. Please
To
continue.
start, my name is Gittenberg, Dr. Gittenberg. I'm neurosurgeon, and do you hear me well? Hello, everyone. Everyone is okay? You hear me?
Yes, we can hear you, doctor.
Okay, I am neurosurgeon in the clinic of University Sechenov University, and today I will talk about the cervical myelopathy. Um, oh, I had the problem with my PC, but now I'm using my my iPad. I wish everything will be okay. I try to do that. That's I don't know what's happened. Screen. So I don't know what's happened. I can send the presentation to you and you will share because I don't know what. Okay, let me. Oh my God. Document. Oh my God. I think it's okay now. Hello?
Play the banner.
Hello, Dr. Gul. Hello?
Yes,
Hello,
hello.
doctor.
Yeah, I'm here.
Hello, Dr. Guive Sharifi. Okay,
I am
Dr. Kutambar, you can continue.
okay. Do
The
you see
break
my,
is
my
over.
presentation?
Please unmute yourself.
Do you see my presentation? Do you see my slide?
Yes.
Okay. My name is Gittenberg. Yeah, I'm no surgeon. And sorry. And today I have to explain you the cervical myelopathy. It's
Hello, Dr.
a bit.
Guive Survey. Are you there?
Hello, I'm here. I'm Dr. Mehrabian on behalf of Dr. Gif Sharifi. Can we start our conversation in 5 minutes?
Okay, fine. Okay, after
Thank you.
the speaker Gutenberg, you need to start your presentation. Okay.
Thank you. Thank you.
Okay,
I
Dr.
have to say.
Gutenberg, please continue.
Okay. Okay. The cervical myelopathy is a big subject, and we have a lot of diseases in our hospital, and I will just explain some stuff quickly, and after I will present my cases. The causes of cervical myelopathy, we know disc herniation, trauma, tumor, and spondylolisthesis. But the degenerative diseases of the spine are the common causes of cervical myelopathy. If you watch very well in my slide, you will see disc herniation, the dehydration and loss of height of the disc. There's osteophyte of the spine. There's also the facet arthropathy. All those things cause the cervical myelopathy. The cervical myelopathy, to continue, the cervical myelopathy is the disease of the spine. But it's not only a disease, but it's diseases of the spine. It's a big subject. And let's talk about disc herniation and osteophytes. Disc herniation is the soft disc herniation may present actually the pain of the spine. It's when the disc increase its form. But soft disc herniation may present acutely or subacutely. But in Russia, we talk about the protrusion, extrusion, and sequest, the three types of the disc herniation. Osteophyte. Osteophyte is when the bone of the spine loses the consistency and it starts to, or it begins to come big. It begins to destroy. It begins to change its form. We have also the hypertrophy of ligamentus. We have the OPLL. The OPLL can produce severe fixed anterior canal stenosis. But the canal stenosis is when you have disc herniation. We have OPLL. We have osteophyte. We have tumor. It may be intramedullary tumor or extramedullary tumor. They decrease the spinal canal. All those things, it's the causes of the spinal stenosis. I won't read everything by words for you. I just explain. And what kind of symptoms we can see when we have cervical myelopathy? The first thing you will see, the first thing the patient will tell you, he or she will tell you, I have neck pain. And after, you have to try to localize where is the pain with palpation, just banal local palpation. And after, you have to test the motor function in the sensation function. And there are other symptoms that you can see if the upper neuron has problem. You can see the dysfunction of the of the of the lower organs. For example, the patient will tell you, I have sensation to pee, but I can't pee. I go to WC, but I can't do it. But you have to localize where is the cause. For that, you have to in MRI, you will see the disc herniation. If it's a disc herniation, you will see the extra medullary tumor or intramedullary tumor. You will see the osteophytes if it's a osteophytes. But before all those instrumental methods, you can just use the neurologic examination. You can check the reflexes. You can see, you can check the motor, you can check the sensory, and you can check the input. You can't see anything in the city, but in the MRI you will see everything very well. Let me try to talk about the treatments, but we are neurosurgeons. We don't use drug treatments for the cervical myelopathy. We just use surgical treatments, the decompressions of the spinal channel or spinal canal. We can do the laminectomy. We do, excuse me, we do the archotomy, we do the corpectomy. That depends of the cause of the cervical myelopathy. Let me show some. It's laminoplasty, laminectomy. I'll talk about it. And okay. I had a patient with neck pain. She comes to me and she told me she has a weakness in the left hand, but she couldn't move her hand, her left hand. But when I checked the neurological examination, I checked the reflexes. I saw the reflexes, they increased, and I understood it was a cervical myelopathy, and I said to her to do an MRI. In the MRI, I found a disc herniation. But I would like to share to you some video. I don't know. What's happening with this PC? But if you have some questions, you can ask about the cervical myelopathy because if you remember when I wanted to start with this presentation and I had difficulty because my PC didn't work very well. I just chose to do it with my iPad, but some images I don't have it in my iPad, and I would like to share to you some cases and with you, but some good cases, some good video.
Thank you, doctor.
I'm done with because I tried to find some images in my iPad. I can find it, but if you have any questions, you can ask me, and I'm ready to answer to those questions. Do you hear me? Hello.
Yes, I think no one have any questions. I would
You
like
have
to request Dr. Sarif to continue his presentation.
Oh, okay. Thank you.
Thank you so much. Hello, Dr. Sarif.
బాగుంటది. రేట్ కూడా మంచి రేట్ తీసుకొచ్చారు. ఫాంట్ సెంటర్ అది కూడా ప్యూర్ టాపిక్ కాటన్, బడ్జెట్ ఫ్రెండ్లీ, కలర్స్ మేడం. చూడండి మంచి వర్క్ వచ్చింది, డిఫరెంట్ స్టైల్లో. వెరీ క్లాస్, కొత్తగా చెప్పాల్సిన పని ఏం లేదు. కంప్లీట్ కాటన్ వస్తుంది. అండ్ ఇది ఏంటంటే స్ట్రైట్ కట్ కాదు, అంటే అంబ్రిల్లా స్టైల్ లోనే వస్తుంది. ప్యూర్ కాటన్ వస్తుంది.
శ్రావణ మాసంలో వరలక్ష్మి పూజ దగ్గరలో ఉంది కదండి. సో మనం రూపులు చేయించుకుంటా ఉంటాం కదా, అలాంటి డిజైన్ అనమాట. రూప్ తీసుకుంటా ఉంటాం. అంటే వాటి ప్యాకెట్స్ తీసుకోవడానికి కూడా ఆలోచించలేదంటే అలాంటి ప్యాకెట్స్ కలెక్షన్ నేను ఇప్పుడు మీకు చూపించబోతా. సో ప్రెసెంట్ ఇది చూడటానికి బ్యూటిఫుల్, చాలా చాలా రీజనబుల్, 320 రూపీస్ అనమాట. యాక్చువల్ గా 1 year బ్యాక్ మనం మేకింగ్ చేసాము. అండ్ నెక్స్ట్ ఇది వచ్చినప్పటికి మనకి మధ్యలో గ్యాప్ వస్తుంది, స్కిన్ ఎక్స్పోజ్ అవుతుంది. 395 మోడల్. దీంట్లో మనకి 4 బ్యాంగిల్స్ వస్తాయండి. ఫోల్డ్ అండి, బ్లాక్ సారీ కట్టుకున్నప్పుడు అలాగా 3. ఓకే, ఇవన్నీ డైలీ వేర్ యూస్ కి కూడా చాలా బాగుంటాయండి. బ్లాక్ సారీ కట్టుకున్నప్పుడు అలాగా 399 రూపీస్. అండ్ కొంచెం యూనిక్ ప్యాటర్న్ అనమాట.
مشکلی که دارم اینه که 2-3 تا
Yeah,
ایرانی
hello,
دیگه
Dr. Giri.
براتون میخرن، میرن اونجا استعلام میکنن. خب
Hello, everyone.
Yeah, hello.
Do you hear us?
Yes, yes.
Okay. Can we start our presentation?
Yeah, of course. You can start your presentation.
Thank you.
Hello everyone, I am Dr. Gif Sharifi. I have a multidisciplinary team. I have a multidisciplinary team of neurosurgery, and for 22 years we work on governmental and private hospitals together, and we have a role in educating residency program and also fellowship program in skull-based surgery. I'm glad to share my experience. I want to share my experience. And
Wow,
do you
great.
see my slide?
No.
We want to share.
I am going to talk today about the
You need to start sharing your device.
Yes, I'm going to share it.
Okay, sir.
Today I'm going to talk about the acromegaly and GH secreting adenoma management. And you see my slide presentation right now?
Yes,
Gitanjali, you see? Yes, thank
yes,
you.
yes,
And
yes.
yes, I made a large series of skull-based presentation, and today we begin with the acromegaly, and I will talk about the a general perspective first, and then I will share with you about 14 cases of acromegaly that we have operated on, and these cases, each one of them has a single point to be attractive for a neurosurgeon dealing with this kind of the surgery. I pass through these things, everybody knows this, and everybody here is a good neurosurgeon, a knowledgeable one, and know that the one thing that is important is the limit of the IGF. In some cases, the IGF is not so high, and if the IGF is more than 1.3, you should assume that you encountered with an acromegalic patient. And it is very important in borderline cases, and especially in the cases that they change their behavior from a mere prolactinoma. Prolactinoma can be changed to a acromegalic because there are some mixed pathology type, and you should know that I passed through these things. We made a Pituitary Excellence Center. In this Pituitary Excellence Center, we should have the endocrinologist, we should have radiologists for intervention, good neurosurgeons. All neurosurgery procedures should be done by at least two neurosurgeons. This is my slogan that I've shared it with any, because two or three neurosurgeons are better in dealing and managing the patient. Safety is going to be high, and you can produce the science. It is very important. And also we have neuroradiologists, neuropathologists, and otolaryngology. And if you want to have a good result, you should stress on having a multidisciplinary team. And also the radiation oncologist should be specified and know the basics needs for cellular radiation. This is not our talk today. I passed through this, and we are going to make a pituitary fellowship also. Set aside the skull-based fellowship that we have, and the pituitary fellowship is our suggestion. And I am going to talk, these data comes out from 450 cases that we have operated on. All of them are acromegalic, which is GH secreting adenoma. This data belongs to the 2020 up to now. And I passed through this statistic because today I'm not going to present for endocrinologist. I'm going to share my experience with a neurosurgeon. It is very important to have a very good and comprehensive pre-surgical evaluation, not to miss anything. And from the pre-metry, the lab data, and MRI, everything should be very good. And for the team that manage the patient, also in acromegaly specifically, the diabetes, hypertension, and the cardiovascular system should be evaluated carefully preoperatively, because the surgical risk is corresponding to these items very clearly, and a post-op period is very dependent on that. Therefore, the sleep apnea test is now concluded in our strategy in management of the acromegalic patients. Excuse me that I hurriedly passed through these things, because I really want to share this with my younger colleagues and satisfy their needs. I passed through this, and for the surgical, we do 99% of the cases endoscopic endoscopic approach. We have chosen this pure endoscopic endonasal approach with a forehand technique if needed, or extended ones through the past 12 decades, and developed it nowadays to approach anything. Again, we should see the cavernous sinus involvement. The rate of cavernous sinus involvement in GHC chronic adenoma is about 25%. And you should know this preoperatively very well. In some cases, you need to go directly to cavernous sinus. In some cases, you should remove the medial wall of cavernous sinus to enhance your surgical efficacy, management, and reaching to the called cure is not a good word, remission. And the reconstruction strategy is very important, and it needs a very large amount of experience, and we are not talking today about this. And the goal is to do the gross total resection, but in the safety of the patient, keeping the neurovascular structure at the most safe possibility. There is now a new drug that I was only want to say about this to you. Time or palsonify is that it shows adds to the drug. Not only know this about the cases. Before I begin, we introduced two ideas about the acromegaly and GH secreting adenoma. One is the presence of empty cella. Empty cella could be associated with the GH secreting pituitary adenoma. It is a very nice idea. I saw this in our series, and I published this in 23 cases. Now we have 80, and therefore, if you see empty cella, partial empty cella, and the patient is acromegalic, it is not as strange to you. It should not be as strange to you. You should search for a small, tiny adenoma in the compressed pituitary gland below that, almost always near to the cavernous sinus. This is one topic that we published. And the other topic that is specific to the GH, secreting adenoma, is the propensity and tendency of this kind of tumor to be grows extracellularly. These tumors could go extracellular early in their course of the growth, because you see there is a cella. Why this tumor tends to go inside the glybus and cavernous sinus early before it's fill the cella and goes toward the supracellular space. This tendency is one of the most characteristic of GH secreting adenoma. Also, I published this recently. 4 years ago, I published this. We want to share with you some class of patients, and this is a case. This is the P-op. The IGF is 8600. And you see this case as I'm going to show it with my mouse. Can you see this with mouse? Gitanjali, are you there?
Yes, I'm there.
Yes, and the mouse showing correctly. Yes, this is the tumor going outside extracellular. This is the tumor. Therefore, you see the cella is empty. This is a characteristic in the cases of acromegaly. You see again the empty cella, partial empty cella, and the tumor that goes early.
Shortcuts, 20 items, postcode, off.
And I passed through this operation video because the lack of time. This presentation prepared before for 1 hour, and therefore I passed through these items. And this is the post-op. In the below picture image, you see the post-op. The tumor is resected from the right side of the gland here, the stalk in the midline, and you see the CSF fill the space. And the IGF post-op reached to the 127, and therefore patients went to remission. The second case is also again one of these cases that I'm going to show you. Here you see that there is empty cella, the stalk is, and if you look at the below of the left carotid, and this is the splayed and it's thin, the 2-3 millimeter tissue, and on the left side you see the adenoma. This is again, I'm going to show you the closer view of the reality of these cases. This is the microadenoma. And early involvement of the medial wall of the cavernous sinus is also characteristic in these cases. I passed to the video. This is two cases that you see, both of them were done by transsphenoidal approach and drilling of the cavernous and meticulously dissecting the normal gland and removing the adenoma. Third cases. This is a case that operated in another center and referred to us because they cannot find the tumor. You see this tumor, this is the stalk. On the left side, you see the stalk, and you see the tumor going superiorly and it compressed the left optic nerve there. And therefore, the carotid is also compressed. If you go through the transcellular approach, you never reach to the tumor. This tumor was going to enlarge through the diaphragm aperture. And therefore, in this case, we do the transplanum approach. Transplanum approach in giant pituitary adenoma is a topic that I will be glad to share with you in the next seminar and the next congress. But in this case, we use these. This was a case of acromegaly. You see preoperatively 900 IGF, and we remove it through the transplanum transtubercular approach. Finding revealed that this tumor is the mammosomatotrope adenoma. Mammosomatotrope adenoma. It means that there is a prolactin secreting element and also a GH secreting element, but this is the mammosomatotrope adenoma. You should have a good profile on pituitary pathology because it is very important. It is the post-operation cases, the post-operation of that case. You see this space is filled with fat. This is the T1, and this is the normal gland. This is the stalk and a normal gland, and you see the fat. The tumor is totally resected. But if you be very meticulously on this image, you will find that superior to the left carotid, we have a thin lamina of the tumor. You cannot remove this tumor with operation. If you explore the cavernous sinus, we have done this 10 years ago. 10 years ago, I explored every cavernous sinus to remove the tumor there, but in acromegaly, you should reach after surgery, you will observe a period of the remission and you will be happy. 2 years later, all of them came back and the IGF is rising. There was a tiny recurrence in the cavernous sinus. Therefore, for cavernous sinus, as the Engelbert-Knox scale more than a 4, it is justified to resect there very safely, not injuring the cranial nerve. But endocrinological remission and cure never happened. Therefore, think about the alternative radiologics opportunity and use them. This is the post-op of the case. As you see here, the IgA from 900 to 300, but never normal. Therefore, I recommend for this case radiation therapy. We'll talk about the radiation and pituitary adenoma in another session, and no, not here. This is a case, again, I use, this is an NFPA, non-functional pituitary adenoma. Why I show this to you, you will find it. I use the transplanum approach again. You see this patient, the tumor is completely above the solar and grows above the solar, reaching, compressing the ambient cistern and the basal ganglia here. And therefore, if you go through the classic transsphenoid, you will end up in 50% removal at most, and the tumor was firm. They tried in another center and sent us and told me that we cannot remove the tumor because its consistency is very, very firm. You know, in this condition, you should extend your approach or you use extracapsular approach. I'm going to be glad. I'm very delighted to talk about the extracapsular approach in another session. We remove the tumor. The tumor, this pathology comes from another center. This 6 months after the first surgery, the tumor was smaller in another center. Again, the tumor is growing. They did another operation. This time is also, they couldn't remove the tumor. This is the second operation. Some pituitary tumor are very firm. This is the operation that we have done. I'm not going to show this movie here because the tumor is look like the brain. They think that it is the frontal lobe coming down and afraid to go enter. This is the brain, it's not brain. This is the tumor. And you see the artery over that mimicking the rectus gyrus and the frontopolar artery. Therefore, in the second operation, the surgeon called me, there is no tumor, the brain comes down. But this is not the brain, there was a tumor. Tumor consistency was firm, and the color is look like a brain. The pathology very interesting. This is a kind of the densely granulated somatotroph adenoma. Because of this NFPA tumor comprised in my slide about the GH secreting adenoma. This is not GH, this is silent, densely granulated somatotroph adenoma. Therefore, in some, this is early post-op, we did transplantum and totally resect the tumor. And again, we entered, therefore we talk about the empty cellular, we talk about the extracellular growth, we talk about the using transplantum approach in firm adenoma. Now we are going to enter to the Kissing's carotid area. Kissing's carotid define if the two carotid in the cell are be closer than 10 millimeters. And this is the case. This is the TX with GAT. You see both carotid are enhanced. This is the supraclavinate carotid and the cavernous. The tumor is here. This is the tumor. And the two carotid is kissing. Surgery is very challenging here. Because if you go there, you will see that you may injure the carotid, and some cases they use the navigation, but the experience can solve this also by looking for the protuberantia of the carotid inside the sphenoid. The pathology here was the gonadotroph. This case was not acromegaly. This case is acromegaly. This patient with acromegaly referred to me because the maximum distance between the carotid inside cell was 6 millimeters, as you see on the left slide. Therefore, I think that how we can approach this, but finding the anatomy, you should be very, very careful about the anatomy. You should see both MOCR, both LOCR, both optic protrusus, both carotid, and open everything in midline to find the tumor. I operate on this, and this is the post-op view. You see the tumor is totally resected, and IGF reached to normal, and a patient hopefully is in remission. Therefore, kissing carotid is not a contraindication to transsphenoid surgery. I heard some centers send them to the gamma knife or something like that. It is not justified, and you should do the operation by experienced team on these cases. Again, another case I will show you about the cases that is going to reach into cavernous sinus. It's a simple case. We have many cavernous sinus involvement. After the operation from the transsphenoid, I passed through this movie. This is the post-op view. 15 months later, the patient is not in remission and receiving the drug, but this this wolf, I don't know, is reduced to the gramophone-like appearance here, and this cannot be removed through the transsphenoid. Therefore, we can do also a trans-sylvian transcavernous approach to remove it or send the patient to radiation. This is the post-op view, and I think we do a transcranial for this patient or send her to the radiation. Another case is cases with McCune-Albright syndrome. McCune-Albright syndrome is a trilogy of the fibrous dysplasia and a pigmented skin lesion and acromegaly. And we have 3 of these cases. You know, this is the fibrodysplasia over the cranium here. And I passed through this. This is the girl. If I show her, because she loves to present it, she said that I am a volleyball champion, and I indebted this to the GH secreting adenoma that I have. This girl is happy with her disease because she is a volleyball player, volleyball team player. And operation on these cases is very difficult. It's a challenge, you know. I operate through this. This is the pre-op MRI. You see the fibrous dysplasia, and the adenoma is here. The adenoma in the middle picture, you can imagine that this adenoma has an Engelbert nose of the 5 or 4. Operation should be in midline with the navigation, with the copious amount of drilling and irrigation to avoid injury to the optic nerve. and I did operation, and I published this 12 years ago. Three cases I had. One case end up in remission and is good now, and one case end up in remission and recurred, and one case didn't remit because of the cavernous involvement. Therefore, approach in the case of the McCune-Albright and fibrous dysplasia is possible, but the result depends on exactly the usual cases, how much the cavernous sinus is involved, but it is technically feasible. I passed through this. The next case is the hyperprolactinemia. Some cases with hyperprolactinemia. This patient was a case of hyperprolactinemia with the left microadenoma. We follow this case because, and you see also the empty cells here, the tumor here, and the patient comes to our clinic and said that recently my symptom changed, and endocrinology told me that you have acromegalic fissure and therefore referred to us for surgery. And I did surgery in this case. This is the early post-op. You see the fat. The red circle showing you that this is the file of graft here. Post-op MRI reading in pituitary surgery need a subspecialty and familiarity with what the surgeon have done in the surgery, and it's a stress over the collaboration between surgeon and radiologist to have a good interpretation of post-op imaging. Another case is the primary transcranial approach for the acromegaly. You see here, these patients came to our clinic with acromegalic fissure and also with diplopia because of the cranial nerve involvement inside the caronal sinus. This is the post-op view. I use the transciliar approach to resect the tumor. This is the normal gland, and this is the post-op. This is the carotid, and therefore, if you choose, I'm not going to show the movie of this patient today, but you can imagine that one good approach for them is lateral subfrontal with a more trional exposure and going transcavernous. This is the area that I entered, but I passed through the movie. This is the carotid. This is the wall of cavernous sinus. Through that, you can remove the tumor, and you see here that I passed through this thing, and this is the transcavernous approach. This was the patient. IGF coming down but not normalized. Pathology was mammosomatotrophs adenoma with 7 to 8% Chi67. It is very important. Don't hurry over the sending patient to radiation with a 3 or 4. More than 3 is a typical okay, but we observe the patient. This patient has a 7 and 8, and during the 3 months post-op, I see that there is a small growth in the cavernous sinus. Cavernous sinus from the post-op MRI was clear, and the patient IGF is going to elevate, and therefore in this case I use a VMAT radiotherapy for 28 sessions with 5040 centigrade. Another case is early cavernous sinus invasion. This patient is with loss of libido, went to endocrinologist. It is unusual presentation for the GHC chronic adenoma. We see this in prolactinoma more and more. And therefore, this patient referred to us with a high IGF. And this is the post-op view. We resect the microadenoma here. And the cavernous sinus was cleaned and removed. Medial wall of cavernous sinus, if the tumor is involved, that you should remove it. This is another case that comes with a macroadenoma. You see, this is the macroadenoma, and this is involvement of the carotid cavernous sinus. And I will show you one movie of our approaches in this case, because if I want to show you a movie, I should I need a large amount of time to deal with that. This is the end of the operation. Therefore, the movie, yes, it's playing. Yes, this is you need in these cases, this is the large macroadenoma with left cavernous sign of involvement. You see the mucosa of the sphenoid is also involved in this tumor. This is the cavernous sign, the tumor removed here, and you will see this is the bulging arachnoid here. This is the wall of the cavernous sinus. This is the carotid inside, and the wall. This is the mucosa of the sphenoid sinus. Don't take it mistaken. This is the wall of medial cavernous sinus. I remove the wall, and you see the carotid medial wall here. You can pass with the curate over the carotid artery bends and clear that. Be careful about the nerves, and I will show you a little movie. This is the carotid inside. Therefore, if the cavernous sinus is involved grossly and a tumor passes through it, follow it through the medial wall. But the lateral cavernous sinus approach is another thing we will talk about later. This is a case, a young patient referred to us with the central skull-base meningioma. This is the case. The patient reached to us with obtundation and diplopia. You see the gland is kept normal in this patient. And we did a transcranial approach for this first. Pathology came to us with the sparsely granulated somatotroph adenoma. Really, preoperatively, I thought that this is a meningioma. The younger with obtundation, diplopia, and a visual disturbance. Therefore, post-op was, intraoperatively, I felt that this should be adenoma because the consistency is different. 3 months post-op, the tumor again began to grow, and the IGF was high. Therefore, it needs the second operation. Therefore, it's very interesting. You see the normal gland here. The tumor is completely supracellular. This extracellular growth again is characteristic of the GH secreting adenoma. If you see this view, you see you will tell that the tumor is above the diaphragm. It is a meningioma, it's not adenoma. Therefore, I did a transplanum approach. I will show you this again. And the movie is not playing, I think. I want to show you the movie here. Oh, yes. Therefore, in these cases, again, transplanum approach. Transplanum approach is the worst things in the armamentarium of a neurosurgeon. You should have it. This is how we drill the tubercle area, how we remove. I pass through this. This is the coagulation of the intercavernous transfer sinus. This is the tumor, because the tumor is above the pituitary gland. I pass through this also. This is the optic chiasm and optic nerve. If you saw the tumor located between the optics and the stalk and the basilar artery. Therefore, if we remove the tumor, we should see the basilar artery well. This is the basilar artery, and therefore this patient need combined operation, one above, one below. Sometimes it happens. Therefore, this is another case. You see here the tumor involved again the wall of cavernous sinus. I passed through the movie. This is something that happened, and you should know that. I operated on this patient many years ago. You see, I removed the tumor. Normal gland is here, and tumor goes to the cavernous sinus. IGF is 854. Pathology is adenoma. This is post-op bio. This is the cavernous sinus involvement. I sent patient to the gamma knife. Gamma knife was done in Istanbul, Turkey. Patients came to me. I cannot tolerate the facial pain. Therefore, the gamma knife can produce the facial pain. You should know this. And this is how the patient tolerate the pain. For 1.5 years, 1.5 years, The patient was intolerant of the pain. Every week she was in my clinic. I prescribed drug. I avoid everything for them. Therefore, after 1 year, the pain abated, and now she is well. I produced this curve to show you what is the exact course of the trigeminal neuralgia after gamma knife. Gamma knife may cure that. I don't believe in this because I'm a surgeon. I operate a trigeminal neuralgia, but some of my colleagues do a gamma knife for this. But gamma knife itself can produce facial pain. Know this. And this is now the patient is very good after 3 years of suffering of both of us, me and the patient. And this is the killing cavernous sinus, and there is no tumor there. Therefore, this is another case I want to show you, and I think we are running of time. And this is the bifid stroke. There are rare cases with the bifid stroke. I had 3 cases in the series of more than near 5,000 cases of pituitary adenoma that we have been operating through the last 20 years. I saw 3 of these. This is the bifid stalk. You see the chiasm here. This is the stalk. This is the posterior stalk. And this patient also had acromegaly, hemicraniadenoma. And we operated. The hemicraniadenoma was on the left side, and patient is very good. Therefore, the last case I will show you is when you should go and do the operation primarily in the cavernous sinus. Yes, we have these cases. This case was a case that you see the tumor is located inside the cavernous sinus. This patient had a good operation before. You see the empty space of the microadenoma on the left side, but the remnant in cavernous grows and it goes inferiorly around the petrigoid roots. I have cases larger than this also. But in these cases, you should use the transpterygoid in the nasal transpterygoid approach and remove the tumor. I passed through this movie. Thank you very much. I tried to cover every cases, interesting cases of GH-secreting adenoma with my friends, and I hope you enjoy and be useful for you. Thank you very much. لازم نشوف هذا چیزی بزنی. بزنی end sharing. Stop sharing. چون چی میگه؟ میکنم قطع شد متوجه شد.
نه داشت اونجا تو پیام میدم. Excuse me.
یعنی یه زنگ بیارو بزن. من میگم
Hello, Dr. Sarifi. Does your presentation over? Yes, hello.
Hello, Geeta.
Yes,
Hello, Geeta.
yes, yes, everything was okay. Okay, fine. Through your email, the participation certificate will be received. Yes, everything good. In the group, you will be getting feedback by our other speakers. Thank you very much, Doctor. Sorry, could you repeat? Video. Okay, okay. The video will be sent tomorrow or wow, that's really very great. Your help will be appreciated. Thank you so much, sir. Thank you very much.